Hey, good morning, everyone. Good morning and welcome, and thank you all for being here today. It's going to be a fantastic day. We expect more people will be rolling in as we go through this, but welcome to the second conference of our Center for Community and Health Engaged Research, Arizona Biomedical Research Center supported education series. This is the second of these for this year. My name's Steve Palmer. I'm a professor in health sciences here at NAU and one of the team members that helps coordinate 5 workshops every year that are supported by the Arizona Biomedical Research Center. So the other members of our team are Dr. Cindy Beckett over there, and then Nick Beckett, who's run around taking care of all things that could ever possibly go wrong. So thank you all. And also I'll introduce Jen Kahn, who's really been the lead on bringing the main ideas for this together today. So I'll talk about her here shortly. But let's see, I want to point to on your table is the agenda, but if you want to read the bios for all our speakers and panelists, the QR code will have access to headshots and bios as well. So anyhow, I mentioned the educational series workshops. There are 5 in the series. Our first workshop that we held last month was coordinated by Pam Buzzard from NAU's Klein Library. And and we examined opportunities for research using the All of Us Health Data Initiative. So that was our first workshop. Looking ahead on March 28th, we've got Dr. Joe Mihalicevic from Northern Arizona University, who's bringing together a number of tremendous scholars to present research and opportunities for using spatial epidemiological modeling for disease modeling and public health. So if you're interested in the research, that might be one to look for. In April 14th and 15th, we're going down to Yuma for our 7th annual border health and rural health workshop with Amanda Aguirre, who is a past state senator and just an amazing person. They're building a new hospital down there that's going to include a lot of the services that many of you all provide or need or would refer folks to. And then we're going to wrap up the year looking at surgeries for improving surgical outcomes, both pre-op and post-op, primarily looking at the importance of resistance training rather than focusing on weight as for surgery pre and post surgery. So that's what we got coming up the rest of this year. But today we're proud to bring you all together to examine existing and needed efforts to coordinate services for those with addictions. Dr. Jen Kahn, who's CEO of Flagstaff Medical Services. Many of you know her. She really spearheaded organizing this workshop, along with our invited speakers and panelists that you'll meet today. Dr. Kahn received her medical degree from the University of Arizona College of Medicine in Tucson, and she's been in practice for more than 20 years. She put a tremendous amount of time and effort and thought into how to structure this workshop. So thank you, Jen, for that. And yeah, we're excited to and appreciate you all coming to participate today. So with that, I think I can pass it on off to Dr. Kahn.
Good morning. Thank you everyone for coming today. When Steve first talked with me about another conference, he asked what I would be interested in hearing about. I started to tell him about my experiences in the emergency room and how it really felt to me like everyone in the community was practicing in their silo, and we really didn't have a good understanding of what we were all doing. We were seeing the same patients, a lot of the same patients, but we really just didn't have, a good understanding. And so I told him I wanted to hear about what everyone else was doing and about what services we had in the community. And my hope was that we would also come to learn where the gaps were in the system. And by hearing about the services everyone was providing, that we could also start to identify those gaps and maybe start to brainstorm ways that we might fill those gaps so we could serve our patients better. And so that's how this all started, and why we are going to be talking about all of the things that we're going to be chatting about today. I want to take a moment and acknowledge that everyone in this room has graciously agreed to come today. Some of you have agreed to be on our panels. None of us are public speakers, including myself. Getting up in front of you all today, I dreaded, I have to tell you. I am sure Dr. Gibson, who's going to be speaking in just a moment here, is also dreading standing up in front of you, just because we all went into our professions to have those one-on-one conversations with our patients. We're all good one-on-one, maybe with the exception of Steve, who is an NAU professor. None of us are used to standing up and talking in front of a room. So I just want to put that out there, that there's a lot of grace here in this room, and very much appreciate the courage of everyone getting up to speak today. So put that out there. I also wanted to share with you an interesting story about this conference as well. I was talking to my mom yesterday about this conference, and the idea behind this conference about bridging resources, learning about gaps, learning about the services that others provide. And my mom said, "Oh, like Miracle on 34th Street." And I was like, "What? What are you talking about?" And she said, "Yeah, the Santa Claus at Macy's starts referring people to gimbals." And it was like an aha moment. Like, we are all seeing the same patients, and we are kind of in competition with one another, our outpatient services. But if we can have a little bit of Miracle on 34th Street magic today, that would be wonderful. If we start to learn about one another, and maybe if a patient can't be served by our entity, maybe we will have the connections after this conference, and we will refer them to the place that can serve them better. So anyway, with that, I will introduce Dr. Sara Gibson, and I am so thankful for Dr. Gibson, and boy, I did not really think that putting together a talk on telehealth and substance use disorder would be so challenging. But with all of the changes in legislation over the last 30 days, poor Sara has been changing this talk almost daily. And I don't know how late she was, probably up last night trying to catch up with all the changes just this week. Anyway, thank you so much for agreeing to be here today.
It is my pleasure. And if you think I'm going to provide clarity, you are wrong. Okay, I have two words up there that are important to me: competence and connection. I'm a psychiatrist. I have been in practice for, I don't know, 35 years, something like that. But I am known for my work in telehealth or telemedicine, telepsychiatry. And okay. A long time ago in a galaxy far, far away. Isn't that awesome? This was in 1996. I was living in Flagstaff. St. John's and Springerville are over there in the purple. And I was then in contact with Northern Arizona Regional Behavioral Health Authority, NARBA. And we were tasked with providing mental health services all across Northern Arizona. And because Northern Arizona is a vast area with a sparse population, we had a big problem trying to get an area that was almost 2/3 of Arizona, but only 11% of the population. And Arizona is different than other rural areas in the country, as you know, because we have a town and then we have space. and then we have a town, and then we have a space. Like Iowa's got town, 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 town. And so people were driving just crazy distances. We couldn't recruit a psychiatrist for Apache County because Apache County, which is in the purple there, St. John's and Springerville, didn't have the population to support a full-time psychiatrist. And so we were looking at all these things to try to do access to care. And I don't know if you know this, but Northern Arizona actually piloted telemedicine worldwide, literally. I mean, Australia was doing some, but we really did it. And so telemedicine was started really in Northern Arizona to provide access to care. And this is 30 years ago. It's brilliant. It bridges a geographic barrier, and it also can serve underserved populations. So we like to say that it has been a massive success, and it has been, as you all know, because we all do telemedicine now ever since the pandemic. It's been very successful. But how do we measure that success? Well, yes, improved access to care. That's obvious. We're able to treat persons and people in their own community without them having to travel to a provider. But we're also able to retain physicians and providers because they don't have to be driving all over, and they're much more efficient in their time. We can do immediate emergency assessments. Before, we were looking at this model where a psychiatrist, and this is before we had nurse practitioners, a psychiatrist would like drive around to all the communities and spend a week here and then be gone for 3 months or 2 months or whatever, and then come back in another couple of months. And this way I can just, hook in on video and be seeing my patient immediately. And so there's entire lectures on the benefits of telemedicine. We also look at patient satisfaction. It's extremely people are very satisfied with the use of telemedicine, and I don't need to talk about that, but we were the first long-term study of patient satisfaction. Cost, it is cost effective, but what I want to talk today about is quality of care and quality of providing care over telemedicine. So we are in a difficult time. We're in a time where people are lacking social connection, and that has been shown epidemiologically to be the equivalent to smoking 15 cigarettes a day if you lack social connection. So why am I talking about connection and machines and technology? Well, telehealth, I believe, can be a bridge over physical distancing to provide us with more social connection. We're in the middle of so many epidemics. We have a mental health epidemic, we have a suicide epidemic, and we have an opioid epidemic and substance use in general epidemic. And so connection is vitally important for us to use every modality possible. We had a talk last year from the Arizona High Intensity Drug Trafficking Area, the Arizona, like sheriff, police people. And the drug intelligence officer talked about the 5, and we're going to have him come back, I think, in April to talk at our Project Echo on substance use disorder. But the top 5 drugs that they're concerned about is, of course, fentanyl, methamphetamine, cocaine, heroin, and marijuana. I don't know if you recognize this little thing. It's called a pencil, but it's a very sharp pencil. And that tiny, tiny white pile on there, that is a lethal dose of fentanyl. That is not carfentanil, which is even more toxic and even more lethal. Of the DEA tested pills that were confiscated last year, 7 out of 10 of those little pills had a lethal dose of fentanyl in them. That's stunning. And look at this. Yum. So these were confiscated in Arizona, and they're multicolored fentanyl pills. They look like candy. 95% of the overdose deaths in Arizona children 17 and under were caused by fentanyl poisoning. Who could stop at just one? It chills my blood. So back to telehealth. Well, why are we mixing these two concepts together? Well, telehealth, and this is my proposal to you today, is that telehealth can provide us competence and a means of connection, and it is an evidence-based and quality of care practice for substance use disorder treatment. So, and I'll go into some of the research just very briefly. HHS did a lot of research and did a huge overview of the research out there, and they found no significant difference between the quality of care, delivered remotely and then care delivered in person for various conditions. It definitely reduces barriers like transportation, but also time constraints. It's a lot more efficient to go to your local community or even in your home and see your provider versus taking, like in Apache County, where they had to take a whole day off of work to drive their child all the way into Flagstaff, or actually even Flagstaff couldn't provide the care. They were having to go to Phoenix or Tucson, take a whole day off of work, drive all that way, maybe have to stay in a hotel, probably get fired from your job because they can't accommodate that. So you're probably just not going to go. And so the increase in services is just mind-boggling and dramatic. And that is also why persons attending remotely had an increase in appointment completion rates, because they didn't have to go so far and make it such a big life event just to go to an appointment. Also, we know in substance use treatment disorders, or not even disorder. I don't even like to use that word disorder. I just like to talk about substance use, that our best outcomes are when people are retained in treatment. The longer you stay in treatment, the more likely you are to have a successful outcome. And so a couple of studies have looked at that in regards to telehealth. This one study on the top, we're talking about buprenorphine, which you may have heard of as Suboxone. Suboxone is a treatment for opioid use disorders. It is a medication that is an opioid replacement. It replaces the dangerous fentanyl and heroin and all of the pills, the opiates that are out there, with a safer alternative that you cannot overdose on and die quickly. And that's why opioids are so scary. So they looked at 92,000 adults who were treated with buprenorphine for opioid use disorders, and they found that if they were treated over telehealth, they had longer retention in treatment compared to in-person treatment. And again, there's that convenience factor. But also retention in treatment among rural populations specific to rural is, again, the same thing, is that it was very effective for treatment retention. And the reduced risk for fatal overdose, this was during the COVID-19 pandemic. There was a 33% lower risk of fatal overdose in persons who were being treated with telehealth versus in-person treatment. But we don't just use meds, right? So there's a lot of things going on that are absolutely essential for treating substance use disorders. And we can use telehealth for case management, peer support, very, very important. It can be done over telemedicine. And also psychotherapy and teletherapy have been studied, and they are very effective over telemedicine. So teletherapy has evidence-based efficacy and improves treatment access disparities in vulnerable populations. This was a study on postpartum depression, and these are women who had given birth, and if you've had a baby and you're supposed to get out of the house with this infant, and you've got breast milk leaking everywhere and there's a poopy diaper and you're supposed to go into treatment and you're just not going to make it out the door. Plus, you're depressed. And so teletherapy was extremely helpful for these women. But also, and this is really important, is that virtual psychotherapy also decreased therapy disruptions. And so when people were getting therapy over telemedicine or telehealth, they were more likely to continue to receive psychotherapy and show up for their appointments. Looking in this right corner, here were Arizona's final statistics. This is really cool. You can just go to that website and you can see the opioid overdoses in our state day to day. But in 2024, we had 4,000 overdoses from opioids. 1,485 were opioid deaths. Heroin, only 2.2%. Interesting. Prescription or synthetics like fentanyl, 97.8%. And polydrug, meaning multiple drugs were involved in the overdose, were 88.8%. They like to talk about these waves of opioid overdose deaths, and we have been in the fourth wave since 2023. I don't know, I feel like we're in a fifth wave, but at any rate, this wave has been associated with a combination of methamphetamine and cocaine, which are both stimulants mixed with opioids. But half of the fentanyl overdoses, when they examine the actual pills, they contain xylazine, or which is very potent and very scary, or 3 or more other drugs of abuse. So SAMHSA, we talk about medication-assisted treatment, MAT. We're actually changing that language from MAT to MOUD, medications for opioid use disorder. The other kind of MAT that's out there in SAMHSA world is medications for alcohol use disorder. If you want to have a whole talk on alcohol, that's a very important one. But medication-assisted treatment is using medications with counseling and behavioral therapies to provide a whole patient approach to the treatment of substance use disorders. Opioid use disorder, just like it sounds, it's a misuse of opioids, various types, but medications for opioid use disorder are first line because, remember, you've got those cute little sweet tart pills out there and they kill immediately and they don't seem that bad. And you've got impulsive adolescents, who's going to stop with one? So medications for opioid use disorder, we really promote, because once you're on these medications, you can't overdose on the opioids. And so that's why we really look at that. But not only are we worried about the acute effects of getting somebody detoxed and onto a safer medication, but opioid use disorder is a chronic disorder and it's relapsing. And so we want to really think about indefinite treatment, like this is a chronic lifelong illness. So why am I going to talk to you about medications? Well, outcomes. So medications for opioid use disorder have a proven efficacy for opioid retreatment in terms of treatment retention. Remember, the longer somebody stays in treatment, the better they do. And also harm reduction, which is a whole other really great topic. So then why telehealth? Well, CDC looked in 2024, and they said that only a quarter of Americans who needed medications for opioid use disorder in 2022 even got them. So we have treatment disparities, but those most in need of the treatment didn't get it. And even the availability of medications for opioid use disorder in community mental health facilities, like our community mental health facilities that we have here. Only 30, and Arizona was included, this looked at 20 different states. Only 34% of these clinics offer this life-saving treatment. So SAMHSA, the federal agency, they have really reduced the barriers that they recommend for getting people on medications. And this is just something I want to talk about. It's pretty cool. It's called Medication First. It's modeled after, many of you have heard about Housing First, which is a homeless assistance program. Medication First is basic principle is get a person with opioid use disorder onto meds quickly. Do not delay, because they should receive medical stabilization meds prior to the whole thing. Like, let's go, you have to do your intake and you have to do your assessment, and then we'll see if we can refer you to a team, and da-da-da-da-da. That's days, weeks, months. They're proposing we get people on meds immediately. Then we start wrapping in all the supports behind that. And then continue the meds. Don't say, oh, you can only be on your Suboxone for 3 months and then you have to taper off. Continue as long as it's needed, and don't have arbitrary discontinuation. You are in recovery even if you're still on that medication. And so something that's really a cognitive shift for a lot of us. When the pandemic hit, I was a Miss Smarty Pants, and I thought I knew everything about telehealth. And suddenly I didn't. And one of the things that happened was that not only did all the patients go home, but the staff went home too. Our clinic closed at Little Colorado Behavioral Health in Apache County. And one of the things that I had to learn about was a home-based induction of buprenorphine. And I'm not going to go into the details about that, but opioid withdrawal is not dangerous. It's painful and it's vastly uncomfortable, but it doesn't kill people. The withdrawal doesn't kill people. But home-based induction seemed really scary, but it's not. And I found literature supporting the use of home-based induction back to 2015 is recommended as the community standard of care. And we have good studies back to 2009. So back to telehealth. And I mean, I have so many things I could talk about, but I'll try to move us through. Telehealth, as a provider, your standard of care is your practice. And providing care over telehealth, you need to have your highest standard of care over that modality, just like seeing somebody in person. So like a medical professional, you need to know that you are finding all of the information that you need to know to make an accurate diagnosis, an accurate treatment, and do what you need to do to make a medical decision. So you have to always be thinking, you can't just say, oh, I'm just seeing my telemedicine, so I'll just skip all that stuff. You got to find a way. So everything has to be clinically appropriate and medically necessary, and all of the same standards, regulations, rules, quality performance measures must apply. I believe that one of the biggest problems with fraud and abuse in the world, and I'm sure you've heard about some of these telemedicine online things that were so lethal. Kid with Adderall overdose, poisoning, died last year, and was a lot of scariness because he just got it from an online person who just asked him a question. Do you have trouble focusing? And then he said yes. And they said, here's your prescription for Adderall. And it's for a lot of it. And so, but identity verification is really important in terms of looking at fraud and abuse. And of course, this online company was not using the standards of care for a medical practice, right? Okay, you can document a physical exam on telemedicine. There's all kinds of ways to do that. There's the things that you're not thinking about that actually you can document that you're doing. Psychiatric physical is very different than, broken bone. But we still are looking at the brain in indirect ways, and you can document all of these things. This Telehealth 10 is a really fun, a patient-assisted virtual exam that you can do with your patients. They even have physical therapy telemedicine, which I was like, what? But they do really well with it. Documentation, got to make sure you're doing all the proper things. Arizona statute, meaning law, you have to document that you've provided informed consent to provide telemedicine. And then you need to document in your note that it was performed over audio or visual telehealth or audio only. And if it's audio only, document that that's by the patient's choice. It's not just because you were lazy and didn't want to put a nice shirt on, or that you couldn't get a connection. It has to be because the patient is choosing that. The new location of clients in the home again, I thought I knew it all. And then all of a sudden, I was trying to figure out how to get connected with my patients in their homes. And that was a miracle and also really hard. So we have all kinds of new in-home standards and guidelines. But again, the same standards apply. You just have to figure it out. You have to figure out a way. But you can establish a patient-provider relationship via telehealth. That's a standard of care. But having proof of identity is really important for identity verification. And so you can have, if they're already known to the staff or the clinic, that works. Previous contact, they can show you their picture ID on the phone, and you can show them your name badge. They can verify things. You just need to make sure that you're really seeing them for what you're supposed to. Ask the patient if they're in a private space. I can't even tell you the number of evaluations and situations where the patient would sit in their car in their driveway because it's private and they could be in a safe space. And we learned so many things about if they're hesitant to show video, maybe they don't want you to see what's behind them in their home. And that's a tricky situation to negotiate and to try to figure out. They may have a perpetrator. If they're a victim of abuse, might be right there in the home. And how can you safely help them out while they're in their home? This is important. You must know where they are in case of emergency, because 911 doesn't work remotely, and I didn't know that for a long time. So you need to know where they are and have a phone number by you in case there's a crisis. So technological barriers, huge in Arizona, so bad in Apache County, but everywhere throughout the reservation, in our rural areas, it's unbelievable how bad it can be. But patients might not have access to equipment. So like a phone with video, they might not have that. They might not have a tablet. They might not even have a computer. But if they do have those, they might not have internet. And it might be that they used up all their minutes on their phone, so they can't use that anymore. Or they have internet, but it's really slow. Or they might not even know how to figure this all out. So we need to do a lot of things to try to help with that. Hybrid models. I'm not talking all or nothing. I'm not saying telehealth is better than in person or vice versa. We're just doing everything the best that we can to reach out. And so a hybrid model is a great model because that seems to have even better outcomes, where maybe you're doing initial evaluations over telemed, but then follow-ups in person. Maybe the doctors or nurse practitioners are seeing people who are telemedicine, but there's an on-site case manager. Maybe it's vice versa. There's not a peer support recovery person in that county, but they can talk over telemedicine. So consider everything that you can do. And remember that it's not about the technology. It's just an interface between you and the patient. And the more that you can make that invisible and just see your person, the better things will be. As you know, treatment is very dependent on the relationships that we build with people, and the technology does not have to be a barrier to that. And that's where Therapeutic Alliance comes into play. A provider-patient relationship with good rapport leads to a therapeutic working alliance and improves patient outcomes. I could talk about this all day, but I'm not going to. There are certain diagnoses that actually do really well and even better over telehealth than in person. And there's a lot of documentation about this. But if you think about when you've had to go into a therapy appointment or a doctor's office, you're kind of self-conscious, like, did I get my deodorant on? Do I have garlic breath? All those things. And then you get closed into a little room with them. That is very anxiety provoking. And for many, many of my patients who have social anxiety, agoraphobia, or trauma history, and especially with the trauma history, that olfactory, meaning smell, all that flooding that you get, the whole thing, it's very anxiety provoking. And I found in my many years of practice that people actually liked telemedicine, gave them that little bit of distance that helped with their anxiety a lot. So it's not a done deal, good, bad, black, white issue. Okay, so there I was. I am doing my thing, seeing my patients. This little pandemic hits, and this gentleman came to me who had he has serious mental illness with a psychotic disorder, but he also had a little addiction to heroin. Not a lot of heroin around, it's expensive, so why not use fentanyl? He ended up moving to the area, but he lived way out in the middle of nowhere, like literally from St. John's, which is in the middle of nowhere. Then you would have to drive like an hour and a half to Witch Wells. Ever heard of Witch Wells? Witch Wells, Arizona. It's just a little, I don't even know what it is. There's a building there. And then past Witch Wells on his dirt road, way out there to his trailer, which was in the middle of nowhere, no services, and that road was terrible. Like we couldn't get case managers out there. He couldn't get in. It was a mess. But we did buprenorphine. We were treating him with Suboxone. The funny thing is, since he couldn't get in, especially during certain seasons, but then the pandemic, all the things, he could only get a cell on his phone if he walked from his house about a half a mile to this certain tree on a hill. So we ended up providing him with a tablet with data plan that he could take to his tree and engage in medication appointments with me. He could engage in therapy, group therapy, intensive outpatient psychotherapy 3 times a week for 2-3 hours in a group. They were all on their tablets and phones and all around. A couple of people would come into the clinic, but it was a very hybrid model, and it worked really well. So that brings us to now, and we have all kinds of new changes in the air. And yes, I was up till midnight. So I'm going to talk about 3 different areas. Well, the SAMHSA, I'm just going to talk briefly. This is about opioid treatment programs, and I don't think that's in our purview to talk about today. That's like the methadone clinic, and they have loosened some rules about that. But let's talk about the DEA and CMS. DEA, think police for doctors. So the DEA extended last year the public health emergency flexibilities around prescribing controlled substances to the end of this year. So right now, we are able to prescribe controlled substances over telehealth without an initial in-person evaluation through the end of this year. Also remember, when we talk about the DEA, we're only talking about controlled substances. So an antibiotic, Prozac, lithium, those things, those are not controlled substances, and there are no limitations on providing telehealth in terms of your licensure. The DEA only cares about controlled substances. So we're talking about stimulants for ADHD, your Adderall and your Ritalin and your methylphenidate. So that's a Schedule 2. And then we're talking Schedule 3, which is buprenorphine or Suboxone, which is a lot of what we're talking about today with the opioid disorders. But also remember the benzodiazepines. That is like Xanax, Valium, those medications. Those are Schedule 4. So the DEA we'll talk about first. First, I'm going to tell you, do I have time? I'm going to tell you a quick story. So I'm doing my thing, seeing my patients. I'm in Flagstaff, they're in Springerville. And I learn of this woman, 80 years old, lives with her husband in her trailer, too hard to get to. And it is during COVID. She just moved to the area. She's on Xanax. She's been on Xanax, which is a medication for anxiety, her whole life, years. And she's on a massive dose of Xanax. And nobody wants anything to do with it because Xanax is a hot mess. It is hard to use. People have horrible withdrawal. It is a controlled substance, and everybody's paranoid about the DEA coming after them if they're prescribing it. Her primary care doctor's like, I'm not having anything to do with that. Nobody wants anything to do with this lady. She just had anxiety, and then the doctor was giving her Xanax for all these years, and now all of a sudden nobody will let her continue on it. So I didn't really want to treat using Xanax, but I also didn't want her to suffer or die from, and Xanax withdrawal is terrible. And Xanax is also associated with dementia, death from all causes, sleep disorders, so she needed a lot of help. Then the next thing that happened is that she had a stroke. And so she was homebound. She couldn't get in and out of her trailer because it had these steps, right? And she's with her old husband. He can't get her in and out of the trailer. So she's stuck in there. So we were able to manage her anxiety. She was also on a list of medications this long. And we managed to get her onto a much safer list of medications. But we were also able to slowly taper her off of Xanax over literally years. And I think she's still on it, but over years. It's not something you can do quickly. And we were able to do that in her home. So that's important. The other thing that's important about my lady is she was on Medicare. So CMS Medicare has the public health emergency flexibilities expire in 1 month. And so we do have a few options that are a little more liberal, but we'll talk about that in a minute. So the DEA, bottom line, we don't know nothing. So everything is up in the air. Everything's scary. We did have a thing. Remember, DEA is the police for prescribing controlled substances. That's all. So, and over telehealth, there is a pre-existing, the Ryan-Haight Act from way back, that people need an in-person evaluation before they can receive services over telemedicine or receive controlled substances. Well, my lady in her trailer, that's not going to happen. And so they did my gentleman who's doing group therapy under the tree, he's on buprenorphine. So they did expand buprenorphine treatment over telehealth, so that it's okay to prescribe it over telemedicine for the first 6 months. And then after that, you have to have an in-person encounter. That's still going to be really hard for this guy. Because remember, we're trying to keep people on this long term because that has better outcomes. So 6 months really isn't enough. It gets you through the emergency. The other rule is at the VA, they loosen the requirements for those patients. But then the third thing that they published is this published rule, proposed telehealth prescribing rule. It is terrible. If you want to read all this, go for it. Try to think through how this would be as a provider. It's impossible. There is no way to accurately be a prescriber and prescribe these controlled substances without over telehealth. And so we're in a comment right now. We're okay until the end of the year, but the comment period, well, I take that back. Yeah, we're okay till the end of the year, but this proposed rule may become permanent. We can comment until the 18th of this month. That's 19 days. There's so much change federally, and the administration has actually told them that they should drop this rule entirely, which actually would be a good thing. And just return to our pandemic policies. But the bottom line is we don't know. So it's scary. Then Medicare. This is got a lot of people very frightened right now because this is imminent. So our flexibilities for this expire at the end of the month. Now, if you're in a FQHC or a rural health clinic, you actually don't have to worry about this till December 31st. But our public health emergency flexibilities are expiring at the end of the month. And what it really means, there's all this verbiage, but the thing to think about is, what is Medicare? Medicare is for people of a certain age or a disability. And so people who have serious mental illness are often on Medicare, and people over 65 are often on Medicare. And so the things that we will lose in our ability to provide telemedicine are geographic. So when I first did telemedicine way back 30 years ago, it was no problem because it was fine if you were rural. But what about my patient who I used to see in Phoenix when I lived there, who was on Medicare, young, like 25 years old, but she had a horrible medical condition where she couldn't tolerate the heat. She was so frail. And she had to take 3 bus connections to get to me in the 110-degree heat, waiting outside. I mean, that's just as much of a geographic restriction as a rural provider. So those are really arbitrary and need to go away, but also in-home. And that's the other thing that will go away and this is a congressional thing. This is, you can call your congressional representatives, and it's their job. And there's some complicated things about March 14th and some laws ending there. And if they don't do that, then this doesn't happen. But basically, we're just advocating for to return to eliminating those restrictions. So what can we do to help? All right, enhance regulatory support. Calling is better than emailing. I've even heard somebody writing hand letters. I was like, wow, haven't done that for a long time. To mitigate fraud and abuse, that's identity verification. And then also improve our care quality. The better care that we can provide, the more that people will be able to come on board with these things. Our technology needs to be a support, not a distraction. We develop a community of practice. Hello, everybody. We are mentoring each other. We integrate care. We use integrated networks. We care management. We enhance ancillary services. Think of telehealth as a house call, a home visit. And that is incredible for diversion from urgent care and emergency room diversion and keeping care locally. And we're also doing a lot of outreach to patients who've not seen a primary care provider and offer immediate in-home telehealth. But here we go, competence and connection. So we have to be competent, but we also need to connect. I love this picture. So be a competent professional in a community of practice, but tech is just a healing modality, and it's just to help us out. I love this quote too. Expertise, ability, and therapeutic alliance are more important than proximity. And I got lots of resources. And I will stop there. And I think that, I'm not sure if those resources are available to you online or something. Okay. Yeah. All right. I'll let you deal with the PowerPoint. I'll leave you with the frog and the turtle and the little snail on the end.
Good morning.
morning.
You mentioned that virtual care patients receiving buprenorphine or in medication-assisted treatment can get up to 6 months. How do they get that? Is it mailed to them, or do they have to go to a pharmacy or
You
somewhere
have
to
to
pick it
go
up?
to a pharmacy.
Okay.
Yeah.
Is there transportation resources? Is that like case-by-case basis? That just seems, for somebody who's getting virtual care because they can't get out of the home, that seems like, another
Exactly.
obstacle for them.
You can mail it, and they do mail it. You can't mail methadone. You can mail buprenorphine, and pharmacies will do that. And they've gotten a lot better about doing that. That 6-month thing is not yet in place. Right now, we can do it forever. But there's also other rules about how much medication you can get, and that's state by state or local. Yeah. Good question, though. That's huge. Or a case manager can pick it up and bring it to their house. Things like that.
Hi, thank you for your presentation. I had a quick question about accountability with the client. So how, with telehealth, can you monitor that they're not continuing the use of the opioid while they're using the MAT service? I know that that tends to be a struggle, or not selling it and using that to buy
Endless
their
question, and I forgot to put a slide in. There's an unpublished, it's about to be published in the Annals of Internal Medicine on diversion of buprenorphine, Suboxone, on telehealth versus face-to-face. And they looked at overdose rates and 911 calls in multiple states. And they found there was no increase in diversion over telehealth versus face-to-face. But that is a huge topic, is fraud and abuse detection. Like, what are we going to do? We tend to rely heavily on drug screens to, show that that the medication that you're prescribing them is actually in their urine and they're not just selling it. I've heard people say, I don't care if they're selling their buprenorphine. That's awesome. We need to flood the streets with it. Don't tell the DEA I said that. But it's tricky. And that's where you have to be creative, be aggressive. You can, I used to have to send people to a lab to get a drug screen, a urine drug screen, when we closed our clinic. And there's, I think a big thing is that you are really dotting your P's and Q's in terms of identity verification, making sure that you know that who you're seeing. The pharmacy also can be a big help in that. They are pretty good usually about identifying if they are suspicious that there's something going on, and they can refuse to fill a prescription. which can be good and bad. I've had it go both ways there. This is where a hybrid model might be good. So like my guy in Witch Wells, I was just like, once we opened the clinic again, like you got to come in every couple months. We'll find a way, we'll get your body in. So you just got to really think about what can I do differently. We have blood pressure cuffs now that we can send out to people's homes, make sure that we're monitoring that. And, in-home drug tests don't really work that well because they're not as verified, but making sure that they're coming in periodically and getting those done. It's a really good question.
Also, next, Jen, you want to come up and help me with this one? So I want to, Matt, there was a question about resources. Yes, Nick will end up posting a recording of this workshop as well as all the presentations and materials, including resources. And you will see an email with that after, once it's posted. So next up, do you want to kind of introduce the idea of it first, or do you want me to just, okay.
So we really want people to connect here today. When we first started talking, we brainstormed ways in which we all might get you to get to know one another. And we came up with the idea of speed dating, speed networking. And so we'd like to go ahead and give that a try. So we are going to have everyone get up. We've got these colored dots, you'll see. The dots are across from one another. And they go through the hall and around. We are going to have everyone stand on a dot, and then we're going to start timing. We'll give everyone 2 minutes of getting to know the person that you're standing across from, and then we're going to rotate.
Hi, folks, we're about ready to get started. So if we can get our distinguished panelists up here. So if Monica, if you're here, if you could come on up to the table, please. Thanks for being here. And then Chris is out in the hall, so he's coming in next. So we're about ready to get started with our next phase of the workshop. So thank you all for coming up. This is our inpatient services panel.
Wonderful. Thank you so much for agreeing to be on our panel today. So we started the day talking about telemedicine. We will talk about outpatient services. We'll talk about residential services, and we will talk about inpatient services. First, I would ask each of you to briefly introduce yourselves.
Hi, my name is Dr. Chris Linsky. I work as a medical doctor, psychiatrist over at the Guidance Center. I've been there since I heard a shout out, love it. And you don't hear that much when you say Guidance Center, so we're kind of excited. Usually you kind of duck and cover, but I've been there since 1994. I also work up in Page, Arizona at a clinic called Encompass Health Services. So I'm not currently on the inpatient unit at the Guidance Center. It's all outpatient services. And but I do work with the providers there and have a familiarity with our inpatient unit that we refer to in general as the PAC unit, Psychiatric Acute Care. Dr. Linsky again.
Hello, my name is Monica Freeman. I work at Flagstaff Medical Center. I am a nurse and clinical manager. We have our psychiatric unit there that serves both adolescents and adults. I've been at Flagstaff Medical since 2017. I'm very proud of the work that we do. And yeah, just thanks for having us.
Hi, Todd Parker. I'm a LPC licensed counselor. I'm a clinical manager. I oversee our counseling team on inpatient. We offer we'll get to that, but offer 2 therapy groups a day. We do individual family therapy as indicated. And I started in 94 too. When I first met Dr. Linsky, we go back. So good to see you again. Thank you.
At this point, let me ask you to talk about the services you provide. Monica, you started to touch on that, but maybe you could talk about first the ages and the services that you provide.
Absolutely. As I mentioned, we are very lucky and privileged to be serving our adolescents. That is a much needed service. We are the only acute psychiatric stabilization for adolescents. And would you say north of Phoenix? Definitely in northern Arizona. The population that we serve right now is ages 12 to 17. I'm really proud of the work that we do in there. It's a really special area. For those of you that have had, family members or experience in different psychiatric hospitals, I feel like ours is really different. We did a huge remodel not too long ago. When you come in there, it is very welcoming. There's a lot of, colors on the wall, a lot of artwork that's done by local artists. So when kids are coming for the first time, it's not as, stark and scary. It's very inviting. The providers that we have there are very dedicated. We've got a team of counselors. As Todd mentioned, we have group counseling. We have individual counseling, family counseling, and we also have what's called the Quest program that allows our kiddos to come on there. And regardless of why they're there, it helps them have an understanding to become self-aware, regardless if it's from outside, family members or, things that they're having on their own. It starts to teach them those coping mechanisms. On our adult side right now, we have the capacity for 17, so 9 on our kiddos, 17 on our adults. Again, we have counseling service on there, psychiatry, med management. We are looking at adding, from the ED standpoint, more of a detox kind of capacity on there for alcohol and opioids. So that's something that we're trying to streamline that process and make it easier for people.
Do you want to add to that, Todd?
Yeah, I can add to that. As Monica said, we employ our counselors. We do 2 therapy groups a day. They can range from process groups, a traditional therapy group, to various psych education. We do grounding skills. We have staff trained in EMDR, CBT, ACT, DBT. We do a lot of those skills just to help individuals learn those coping mechanisms. We try to accomplish at least 2 sessions with their adolescents, given our length of stay is about 8 to 8.5 days. A lot of that is to at first talk about what brought the individual in, as well as how to break down any barriers when they go home. We know that communication often is very difficult. Trust has been broken. So those are the things we target. Very solution focused, given our acuity and short-term stay. I would say in addition to that, we do some individual therapy. We don't do EMDR in the unit. We might maybe do calm, safe state. Those of you that know what that is, just to help them ground and do some of that. It's very difficult to start something and not have any wraparound if they were to leave with that. So, and also nurses do a group a week. We do yoga therapy once a week. We have community members come in and do an AA meeting on our unit once a week on the adult side. We're trying to expand that to the adolescent side and more frequently during the week. So those are the services.
And thank you again. I'm Dr. Linsky. Just to summarize, at the Guidance Center, we have a pretty broad spectrum of services, very similar to our partners over at North Country. I still call you guys FMC. Yeah, that's just years of doing it. So a lot of times in our communities, people's services are divided by funding source, which isn't a shock. A lot of times the Guidance Center, and you guys can correct me if I'm wrong on this, our emphasis a lot of times is on community mental health members that are either enrolled with SMI services. You guys know what that is? Yeah. SMI stands for serious mental illness, which is basically a state categorization for people that have a severe mental health condition, that have an impairments associated with it, and then they qualify for state services regardless of insurance. So whether people have access, which is Title 19, or any other funding source, the SMI services are generally coming to agencies such as the Guidance Center. Now there's at least one other agency that does SMI services in Flagstaff, and that's Southwest Behavioral Health. They probably have maybe 10 to 15% of people with SMI designation, and we have probably the remainder. In addition, we generally see people that have something called access. You guys familiar with Access, Arizona Cost Care Containment System. And basically that's a combination of federal and state dollars that pay for services, typically a combination of inpatient and outpatient services. In addition, we have something called the Title 36 contract that you guys have been very wise to stay far away from. No, it's a great funding source, but it's a very challenging population to work with. Title 36 basically is a civil law system that we have in Arizona, which allows people to have their rights restricted because of concerns of mental health conditions. So if someone has an identified treatable mental health condition that puts them at imminent risk to themselves or others, that's not caused by an underlying medical condition such as dementia, that's not caused by a substance use disorder, then an individual in the community can start a petition. Basically, it's just a piece of paper that's notarized that allows the provider to contact the police or law enforcement to bring that person either to the guidance center or to FMC. I'm looking at Steve back there, FMC, for clearance, and a lot of times they'll end up getting admitted to our place. So our inpatient unit, called a PAC, has 16 beds technically, but we can max out to 18 beds with our seclusion rooms. Our primary commitment is to individuals under the Title 36 contract. That's because there's really not any other mechanism or another place for them to go, which can be a challenge because you don't know. There could be 2 people, there could be 12 people. I think right now we have about 8 people under what's called a Title 36 petition. So someone who perhaps was hearing voices that was telling them to harm themselves, the mom or someone could have started a petition. They come into us and they have like a 3-day period to be seen by some providers, a 3-day waiting period, and a 3-day court period. So it gets a little complicated and we don't always know who's going to be there. In addition, we have people that are either voluntary, that are typically SMI, or have access, or people that came in on crisis. And that population a lot of times will involve people with mental health conditions that are traveling through town that don't really have a funding source. Maybe they're going from Oklahoma to California, and we're fortunate to be located right in the middle of I-40, and they stop and visit Steve and his friends over at the FMC. And sometimes they come to us and sometimes they go to you guys. And so our funding sources are pretty wide and varied. We try and maintain access for individuals in particular with substance use issues that need medical level detox. One of the things that we found though is that our staffing or our capacity doesn't meet the need in the community. So about 6 years ago, we started another program called the CSU, the Crisis Stabilization Unit, which has had varying degrees of success, admittedly. Sometimes it works great, and sometimes, honestly, it doesn't work very well at all. It's intended to be a 24-hour sort of staging place to figure out how to help and support people through crisis that maybe don't meet the needs of an inpatient unit or are more temporary, someone who needs to get back on their meds. And I would say a large percentage of our CSU folks, I believe, Stephanie, I'm going to ask you, Dr. Babbitt, is it 6 beds we have or 8? 7. Right in the middle. I missed it. There you go. She's good. So we have 7 beds, neither 6 nor 8, but somewhere in the middle. It's like the holy hand grenade. And so with the 7 beds, I would say at any given time, about 4 to 5 of them, or roughly 2/3, are going to be filled with people that have substance use issues, people with chronic alcohol intoxication, people that have opiate dependency issues, people that are withdrawing, that will come in. We have 23 hours to assess them and hopefully transition them either to the inpatient unit if needed, or develop an outpatient plan to help them detox on an outpatient basis. Or Kelly is here with us too. She works in what's called our SARP program, our Substance Abuse Residential Treatment Program. And we could try and get those individuals up there. A lot of times it does depend on the individual's motivation. Sometimes they want to come in just to have a place to stay, which is okay. Sometimes they really are ready at that wheel and cycle of recovery to get some help. So we have a wide variety of folks. We do provide inpatient detox when necessary, though a lot of times people will go to the CSU for 23 hours for assessment before transitioning them to our inpatient unit. So kind of an overview of our services. And I know Kelly is going to be up here and she's super excited about public speaking. Is that right? I think so. Yeah. No, so ask her all kinds of questions. And she is going to talk more about the substance abuse program in specific, because that's a program that we've had for many years and has been very effective in helping folks in our community.
What is the average length of stay, do you think, on the PAC?
The pack again is going to be very skewed. The average length of stay is typically 3 to 4 days. And that's quite varied because sometimes you can have people, we have people that are there sometimes 3.5 to 4 weeks. We have a person there now who's been there 6 weeks. The median length of stay is probably closer to about 7 or 8 days in terms of looking at the middle, because we have quite a few people that will come in, spend one night and decide, I really, don't want to be here, or they're maybe not as committed to the detox process as they had planned. Or sometimes people get scared, to be honest with you, because we have a wide, diverse population of individuals. Sometimes we'll have people from the jail that have very profound psychotic disorders, and you might have someone come in to address depression and suicidality, and that environment can be very disconcerting for a young person, and they can request to be discharged, and we work to try and help them get transitioned. But the length of stay, if you look at the paper, I think it's like 3.5 days. But again, it's very skewed by the populations that we see.
And how do people get onto both of your inpatient units? Can you talk about that a little bit?
I'll give it to Monica. Sure, I can. Well, through ours, we have a couple ways. Hey, Kurt. Through our agency, we have a couple ways. The most common way is to come in through our crisis program. Our crisis unit will see people 24/7. We have a crisis unit that people can either walk onto or have the police bring them. And that's probably the most common way. People might come as a voluntary person, indicating they have maybe thoughts of suicide, they need to get back on their medications. They might more commonly be brought in by the police. The police might bring them in and say, this person was being disruptive in the community. We started a Title 36 petition. They'll be seen by a crisis worker and get admitted. It can also come through an outpatient doc. So if there's an outpatient doctor at the guidance center who thinks that the individual meets the level of criterion, they can admit them directly. For members of the community that might be providers that want to refer someone, in my opinion, I'll defer, Dr. Babbitt will be able to address this as well. The best way for me is I usually say, have them come to crisis and present themselves and explain the services they need. And they can, a lot of times, have their medications adjusted through a provider in crisis, come into the CSU to be seen by a nurse or provider to have their meds adjusted, come into the PAC, or have an outpatient plan developed. But coming to the crisis unit is generally the most efficient way to do that. I'll turn it to Monica and
Sure. I'm Todd again. We have an assessment referral team. We see a lot of our patients come through our own emergency department. Many of them are in acute psychiatric crisis. Oftentimes, common is suicidal thoughts, suicide attempt, general thoughts of wanting to hurt themselves or others. Acutely psychotic, acutely manic. It's the highest level of care, so we make sure that they meet the criterion that they're voluntary to come to us. So a lot come through our own emergency department or our medical floors if it's a status post, say suicide attempt. In addition, we take from outside emergency rooms. They've been assessed, they've been evaluated, they refer to us. We go ahead and we staff with our psychiatrists and bring them in. Our length of stay for adults right now is about 5.5 days, geometric mean length of stay. In addition, our adolescents about 8 to 8.5 days. So a little bit longer for them. What often drives up the numbers with adolescents takes longer. Like I said, we want to make sure we do the family sessions a little longer to make sure that medications are working well, but oftentimes it's waiting for residential treatment, which is a hard thing to find when you have a teen that needs that, and getting a bed and have an opening and getting everything arranged is often challenging. Trying to think what else.
And actually, if you could talk about your biggest challenges, maybe is my next question for you guys.
Yeah. I think the biggest challenge we have is our adolescent unit. We're only 9 beds. And we're the only 9 adolescent beds north of Phoenix, and oftentimes not having to send referrals from, say, Tuba City or Chinle when they call us and we don't have a bed. It's a hardship for the families to go all the way down to Phoenix or even as far as Tucson. So those are some challenges that we have. Often challenges are with the discharge process, getting them into the service and resources that they need. If they're uninsured, underinsured, trying to get them connected with services, make sure they can get on access or whatever qualifications we have. We definitely want people to leave with appointments. We want them to have a safe discharge, and that's sometimes the challenges that we have, limited resources or lack of funding for that matter.
I think you covered everything perfectly, as usual. The only thing I wanted to add is in our inpatient program, another service that we provide is starting for electroconvulsive therapy. So sometimes we'll get referrals from outside people that have been experiencing treatment-resistant depression. It's a program that's near and dear to my heart. I've been with some of my patients for over 8 years, so that's another resource that we have for people. So they can go about it two ways. It can go through outpatient, but a lot of times people will get referred and they'll start on the unit. And then they'll stay with us. It's a index course of 12 sessions. So that's Monday, Wednesday, Friday. So sometimes when people live in other areas, that it's much easier for them to stay in the hospital. So making sure, again, like the resources after they're with us are always a challenge, but insurance too. A lot of these, kiddos that come to us that are in crisis, if they've not had any outpatient before, sometimes the residential, programs will say, hey, you need to try this, first. And then sometimes it doesn't work. Charlie Health is a wonderful resource too that we've been finding for kind of that bridge between, face-to-face and online, programming as well. So thank you. Yep. So Charlie Health, the way I understand it, the inception was before COVID. So they actually developed it telemedicine without like changing from normal practices to telemedicine. So they've got a wide variety. They take a lot of different insurances. I believe they take adolescents and then up to the age of 33, I think. But they offer, especially for small communities like Flagstaff, it's just a wealth of different programming that can be kind of tailored to the needs: depression, anxiety, gender dysphoria, different types of I'm just trying to think, like they do music therapy. But the nice thing is it's across the country, because we know in Flagstaff, everybody knows everybody. And, you can have like a lot of our kiddos that come on the unit, and it's hard because, you're dealing with your stuff, but you totally know this person or this person. So they break it into groups. So you won't necessarily be with people in your area. So I think that kind of gives like a broader dynamic, but that's a different program that's a resource for you guys.
Dr. Linsky, challenges that you see on a daily basis?
I can't really think of any. No, I'm just kidding. There's a few. So, but first off, we have some great strengths, just to focus on the positives. One of the things too, just to do, and I saw Dr. Mueller walk in. I just greeted him. He's a gentleman I've been blessed to know for many years. He is actually spearheading a process that's kind of exciting with these guys as well. We're trying to develop a residency training program here. So, Kurt, I'm putting you on the spot. Is it okay to talk about that? Yeah. Would you actually just want to mention it? If that's okay. So this just, he is the expert in all things residency. It's really exciting stuff. So I just like to invite you to share on that, because that's really cool.
Hi, everybody. Nice to see you. I'm Kurt Mueller. I'm a psychiatrist. I've been here in Flagstaff since the late 1990s and have been primarily in private practice during that entire time. I joined a couple of years ago a new project to start a psychiatry residency training program hosted by North Country Healthcare to join the family medicine residency that is already up and running and very successful there. And we've been in startup phase these last couple of years. We are working very hard to develop our collaborative relationships with training partners, the two most important being NAH Flagstaff Medical Center and the Guidance Center, along with some others. We are doing this project because there's such a need for psychiatrists throughout, not just our local community here, but all of Northern Arizona. And we hope to train psychiatric physicians who want to stay in this region. There's a lot of evidence to demonstrate, and family medicine has also been an example of this. If you train them locally, a significant percentage will stay. And so this is a very important part of our mission. We want to be training folks to address a broad range of the community needs that we have. Pretty much every sector in the mental health system, as many of you know, has need for more psychiatric input. We are on course to submit for ACGME accreditation this summer. And if all goes well with that, then we will expect to have our first resident start in the summer of 2027. It's a very long startup phase. And then since it's a 4-year program, we'll be training 4 residents per year, and it's 4 years. We don't actually have our first graduates until 2031. But if you don't start, you never get to that endpoint. So we're very excited about it. There's been a lot of community support. All the folks that we've been meeting with and collaborating with have expressed very strong interest to support this. And so we're very grateful for that. Questions?
Do you guys, when he talks about residency training, do you guys know what that means? Just, it's okay if you don't. Do you guys? Okay, because it's a long process. So it's just, you have to go 4 years of undergraduate, then 4 years of med school, and then you have to choose your specialty: family practice, dermatology, psychiatry. So really, it's when you leave high school, it's about a 12-year process to go through it. So this, we're talking about the last 4 years of that 12-year process. And the big challenge we'll have is recruiting here. And so I think this is probably the best thing that could happen. As much work as it is, I think it's really going to pay off, but it is a long-term strategy for sure. Cool. So that's one of our great strengths, is that to have a community partnership with the folks over at FMC, with a North Country Clinic, just to be able to bring this to staff more people. The other great strength that we have too at our agency is a little bit different, called nurse practitioners. Is anyone here a nurse practitioner? Okay, do you guys know nurse practitioners? A lot of times when we go to our PCPs now, we see nurse practitioners. MDs and DOs kind of operate in one silo. Nurse practitioners operate in another silo of training, and that's more specialized in psychiatry, whereas MDs generally tend to be more generalized with a subspecialization. So one of the things we have at the Guidance Center now, we only, I believe, have 3 MD DOs, and I think we have about 7 or 8 nurse practitioners. And we have on our inpatient unit, we have a nurse practitioner and a MD working together to provide services. So again, some of the strengths we have are working with community partners to build better resources and services over time, and also our current staff. Probably the greatest challenge we have, just to echo on what Todd referenced, is discharge planning. Many people come into us with a very high level of acuity and need, lack of services relative to housing, funding, maybe legal charges they have pending. And we have about 5 or 6 days to wave the magic wand and try and fix things, which our magic wand has been broken since I got here. So we're not really, so we try and do what we can, but a lot of times when we're looking at discharge planning, a lot of it has to do with trying to engage outpatient services such as substance abuse treatment, case management, enrollment in food stamps programs, to make sure that when people leave, there's not this rapid decline to the point that would require them to be rehospitalized. And our insurance companies, as you guys probably know, have a very tight window of time to get people better. And that window doesn't really reflect the reality of how long it takes for someone to stabilize. So a lot of times we end up having the barriers of not getting funded for people that need to be there a little longer, or fighting with insurance companies. I shouldn't say fighting, but presenting to insurance companies reasons that people need to stay, and then trying to engage outpatient services that can help support the person once they leave. That would probably be the greatest challenge. I guess the other challenge too is for us, a little different than you, with the population diversity we have. Sometimes we'll have people on the unit that have psychotic, violent episodes mixed with people that have very different issues, maybe mood related, suicidality related, substance use related. And those two populations can be very challenging to integrate, because it's very scary to be with someone, as we might know, that who has the tendency towards violence as driven by psychosis. So those would be the things that come to mind. So despite our strengths, we certainly have our degree of challenges too.
Oh, what questions does the audience have?
From your CSU? Either of you? You don't have a CSU.
No, yeah, in our CSU, yes, we can. We can start that. So what she asked was, can we start buprenorphine detox from our CSU? And again, the CSU is that step down level, crisis stabilization. We have done it before. The protocol is not a firm protocol. The provider will get engaged. Many of the people that come in will already have been doing their own informal detox with buprenorphine. They'll be probably, getting it in the community, which is a safe way to approach it. But yes, we can start it there. And
And I should have said induction, not detox.
it's okay. Yeah. So
Very different concepts, actually.
yeah, so the concept of induction is when someone has a opiate use disorder and you start Suboxone, when you first started, if they're still sort of high, do you guys know what happens? They get really sick and they sort of hate you. And that's an okay thing because the way Suboxone works, or buprenorphine, it's incredibly cool. It goes and displaces the opiates that they're on. So if someone's on heroin or OxyContin or fentanyl, if they take the Suboxone, it will induce them into a state of withdrawal. And it lasts any place from 2 to 4 hours, and it's a very difficult time. However, if they can get through that induction, they tend to do better. The ideal thing is to wait until someone gets into detox, and then you start them on the Suboxone so that you're not causing them to withdraw. A lot of times, though, the time frames don't line up. Someone comes in and they've been using, and you have to start them, and you actually induce a withdrawal. A lot of times, the preference overwhelmingly would be to do that on the inpatient unit. If the inpatient unit is not able to manage that, we can start it at the CSU and try and maintain people. But again, a 23-hour window is a very brief time. But yes, we can do it, although we'd prefer to do it on the PAC or the inpatient unit. Do you guys want to address that? The Suboxone induction?
So I would say that we don't typically do the Suboxone. There have been some cases that we have. We are, like I said, working on collaborating and developing a detox program, like more system on the unit. There's people that come in that are waiting for residential that are on Suboxone and will continue it. We don't necessarily start it on our unit. However, we are working to streamline the process for alcohol withdrawal. Down in Verde, we definitely have that, where if you go into the Verde hospital down there, they have an addiction specialist provider there. I think we can do same day. And then you can also get in with the counselor down there too. That's specific for that one too.
Well, I guess where I was actually going is that since the CSU is 23 hours and they might not yet be in withdrawal enough to start the induction of the buprenorphine, I'd really like to encourage more in-home inductions and sending people home with that buprenorphine and supporting them in doing that on their own with your support.
So just because that's again, buprenorphine, what she's talking about. So buprenorphine, okay. Suboxone is the compound that we talk about. And all medications for the most part, except chloral hydrate, has 2 different names. I actually looked that up once. And so it gets confusing. So there's this magic thing called buprenorphine, right? Buprenorphine is a pain med that came out in the 1995 or 1996. And we are going to use a term called an agonist. An agonist is something that activates something, and an antagonist is something that shuts it down. So if you think about the ignition of your car, if you put a key in and turn it, that's an agonist. You're activating your car. If you get a wad of bubble gum and stick it in your ignition key, those that still have those back in 2006 Hondas that are awesome cars, that's an antagonist. You can't get your key in there. Now we're going to talk about fobs right now. Okay, so buprenorphine is what's called a mixed agonist antagonist. That means in our brains, we have 100 billion neurons, more or less, and they have these things called receptors. And receptors are just a fancy name for a complex molecule of carbon and phosphate and hydrogen and stuff. And so when you take a compound, whether it's caffeine or marijuana or alcohol, it gets into your brain and it interacts with these receptors on those 100 billion neurons that changes the way electricity moves in your brain. So opiates, if someone took fentanyl, they would take it as a compound, it would go magically to the brain, and it would attach these opiate receptors that make people calm down, block pain, suppress respiration, and generally activate a pleasure cycle through another compound called dopamine. So it activates those receptors. It's very much an activator. So even though it's shutting the system down, you're activating the system, which leads to shutting it down. Buprenorphine was found to be a mixed agonist. That means it activates some of the receptors, but it turns off other receptors. So it does a little of both. It's like putting the key in and turning it halfway. So you get the radio, maybe you get the fan, but you don't get the AC and you don't get the motor. The things that it tends to activate is it activates pain, and it tends to activate It covers withdrawal. So it tends to block the sense of withdrawal. What it doesn't activate is it doesn't activate respiratory suppression, and it doesn't do much for the pleasure pathway. But it tends to block people from having the withdrawal. Now, if someone's on buprenorphine and they take fentanyl, the key is already in the ignition. Another key won't fit in there. So fentanyl just doesn't work. So one of the cool things about it is if someone's on buprenorphine and they go out and they take some fentanyl, they don't feel it. They just wasted $20. If someone injects with heroin, they'll probably feel a little bump from it, but they won't feel much because the receptors are already activated. So what Dr. Gibson is talking about is that buprenorphine, if someone's already on fentanyl, it is a more powerful agonist than the other things we have. So let's say someone's on fentanyl and their car is running and they're feeling high, they're feeling buzzed, they're feeling really good. If you give them Suboxone, what happens is that key for fentanyl comes out of the ignition, Suboxone goes in, it turns it halfway on, and they feel like crap. And they feel like crap for about 2 to 4 hours, typically. And they're really mad about it and they feel bad about it. But the good news is typically, and I'd be interested to see what other providers see, after about 4 hours, withdrawal, that can take 5 to 7 days in some cases, gets a ton better. So if you can get them on that initial dose and they feel crappy for a while, then they're able to transition to a more stable compound ongoing, so that if they're on the buprenorphine and they use fentanyl, they kind of can't die. It's kind of a really cool magic thing. What do you see, Doc, when you start people? About 4 to 6 hours of withdrawal?
And actually, my question to you is that you have them for such a short time, even if you don't have that window where they're in enough withdrawal that you can less comfortably give them the buprenorphine, you can send them home with instructions to monitor their own withdrawal, and then they can figure out when to take the buprenorphine themselves at home and initiate that induction to be on buprenorphine, which saves lives because they can't overdose on it.
Right. And so what she's acting is if someone comes in who's actively intoxicated with fentanyl, we have a couple choices. One would be, like Dr. Gibson says, if we provide them with like 4 pills of the 2 milligram or 4 strips of the 2 milligram, we could advise them, when you start to feel detox, take one, wait 2 hours, take another one, wait 4 hours and take the other 2, and then come back and see me tomorrow. Or if we're concerned about that, we could just say, look, we're going to start you on this now because I know you want to be on it and you're going to be miserable. And you know what? That's going to be okay because we're going to give you some lorazepam. We're going to give you something to help you get through it. And we're going to go ahead and just start it. Even though you're not withdrawing now, we can induce a withdrawal with it. But the preferred one would be to send them home. A lot of times, though, we're concerned that the people won't do that. They won't take it. So we would start someone potentially that's not yet in withdrawal on the Suboxone to catch them within that window because it's such an effective medication. So we've done both before. Technically, you're supposed to induce or start someone when they're in the unit, but sometimes that's just not practical. It just doesn't happen. The one last thing too, just a little nomenclature or name thing, Suboxone. What happens is if you prescribe someone Suboxone, you're giving them a combination drug. You give them buprenorphine, which is that wonderful agonist antagonist, and you're also combining it with naloxone, right? Naloxone, 2 milligrams. And so the reason they do that is there was some early evidence that showed that if you took the pure buprenorphine and you broke it down by heating it, it would become a potentially active chemical that could be injected and changed to a straight agonist that could be abused. Subsequent to that, it seems like that's not really real. That doesn't happen. But they had put the naloxone in to prevent people from being able to abuse the Suboxone, although now it seems like Suboxone is actually not easy to abuse. But yet we still call it Suboxone because it's combined buprenorphine with naloxone, which is intended to prevent IV use, which could be seen as more for abuse as opposed to treatment. So I got totally off on a tangent there, but that was a great question. But yes, we do it. Sometimes on the unit, sometimes at home.
We have about 5 minutes left, I think, for this panel. I'd like to shift gears just a little bit and ask you about alcohol withdrawal services. We definitely have a alcohol problem in northern Arizona, and we very frequently get patients in the emergency department asking about inpatient services for alcohol use disorder. Can you talk about that a little bit?
Sure. On our unit right now, currently, we will see patients that maybe have an acute mental illness in combination with alcohol withdrawal. We treat them with a SAS protocol. We monitor their vital signs to make sure we stay on top of it. Remind me of the current meds we're using in process with that. Ativan, yeah. So we treat them accordingly to help them safely withdraw from the substance, to not put them in a withdrawal. We want to avoid seizures. Once we get them through that process, then we set them up, hopefully with some outpatient services. On the medical floors, what we often do for severe withdrawal, they'll use Precedex. Is that right? Yep. They'll do that for people with very high blood alcohol levels or very longstanding addiction to alcohol. Currently, we're working on a process to be able to do more work with just straight detox and not have it in conjunction with a mental illness such as acute suicidal thoughts, psychosis, bipolar disorder. But we use the SAS protocol. We make sure that we maintain their vital signs, which is often uncomfortable for the patient because we're checking vital signs every 1 to 2 hours through the night. We let our patients know that they're going to not feel the greatest, but the benzodiazepines help to help them through that process, be more comfortable and avoid seizures.
So same thing too. We use medication similar to lorazepam, and that's a medication for alcohol withdrawal. We'll do that at the guidance center. In general, let me see. What do you think is more serious, alcohol withdrawal or opiate withdrawal? Just show of hands. Who thinks alcohol is more serious than opiates? How about who thinks opiates is more serious? Anyone? It's okay. Put up your hand. So, and they're both serious. Generally, and I'll be open to feedback as with all things, but generally alcohol is seen as more serious. You can actually die from it pretty effectively. Alcohol will kill you. Opiates, not really so much. You'll feel really crappy, but you generally don't die from it. But alcohol withdrawal is really serious. So a lot of times, Dr. Gibson's question, if we had a choice to admit someone for opiate withdrawal or alcohol withdrawal, we'd probably admit for alcohol withdrawal selectively because a couple things. The medications like Todd mentioned, lorazepam or Ativan, if you give that to someone and say, hey, take this home, Dr. Gibson, and take it 1 every 4 hours and don't drink your vodka. Well, naughty Sara, she might just go and decide to combine them. And that's kind of lethal. When you combine benzodiazepines like lorazepam with alcohol, it's very effective at killing someone. So however, if I send Dr. Gibson home with her Suboxone and say, don't take your fentanyl, and she decides to take her fentanyl, we don't really care. She's not going to feel it anyways. So alcohol detox is a bit more serious in our book because it does tend to be lethal. So on the inpatient unit, similar to these folks, we use what's called a withdrawal rating scale. And we used to, I'm trying to think of the one that we used. I don't remember the name. Dr. Babbitt, do you recall the one we used on the unit? The OWL is for, what's that? For the alcohol, I don't recall, but there are names, and basically what you do is you get points. So if we were to have someone who's withdrawing, would say, we're going to check your blood pressure. If your blood pressure is over this, then you get 1 point. And then we're going to check your pulse. If your pulse is over this, you get another point. Then we look at your tremulous. If your tremulous is over this, you get another point. And so that series of points adds up to whether or not you rate high enough to have a dose, or just subjectively. A lot of times subjectively, we can use medications like lorazepam on a scheduled basis over 5 to 7 days to safely detox people off alcohol so that they won't have a withdrawal seizure, which is the common mechanism of death with alcohol withdrawal. So yes, we do that, and we probably were more skewed to do that than opiate withdrawal, just again, because of the lethality. But a lot of times people choose to leave before they make it through, which puts them at high risk of relapse because they're going to feel the withdrawal, and alcohol is a very effective way to prevent withdrawal.
What questions do you have?
I have a question for them. You guys in the community, if there were one service, inpatient service, that could be available to the people you treat, what would you guys most like to see? And that's not just a rhetorical question. As Dr. Mueller has been working on the program, we're at a point where we can actually make changes and do cool stuff. So he's developing a program where the residents over the course of the next 2 to 7 years will be doing things in the community. So when you think about things that you want, what would you most like to see?
I would say nationwide, what's lacking is just addictions treatment in general. So if someone has a gambling addiction or if they are addicted to porn, right, that there's not really a treatment center that they could go to. We really have that in silos, and we know access to substance use treatment is so narrow. So I would just say addictions in general. I think also eating disorders fall into addiction. So that's what I would think would be beneficial, instead of us saying, well, if you have an eating disorder, you have to come here. If you are addicted to gambling, you have to go here. So letting it be more accessible just to addictions.
More broad. That's a really good point. That's something I'm not familiar with services. I know most of the eating dependency or eating addiction issues are not in our catchment area. They're mostly further south. Do you want to comment on that in terms of other addictions? Do you have any access to services that you know of?
We used to have a LISAC who was able to provide gambling addiction therapy. It was through a grant through the lottery. And currently he's long since retired. So I don't have anyone that can be licensed officially to do that, but we used to offer that. But I agree with you, addictions in general, you're going somewhere for that, right? And there's a few, like we have our addictions psychiatrist in the Verde Valley area that is up and running, trying to build her clientele. But aside from that, it's very challenging, and it would be nice to have something, and even like residential programs, things like that with long-term programs, especially eating disorders. We know that that's often a very lengthy stay for some and would be awesome. I agree with you.
Thank you for commenting on that. And yeah, it is partly too, I think being a smaller community, you have to have the numbers to support it. And so combining it, I think would be a good idea, because then it's not like, oh, we need to have at least 7 people with gambling disorders to keep this going. But if you had a combination, it could work.
I think one of the resources that we're missing, not only in Northern Arizona, but across the state, are inpatient facilities that will accept an individual with autism spectrum disorder. Last time I looked, you could go to Phoenix Children's Hospital if you were under the age of 18. They'll keep you for a brief amount of time if they have room. And then there's the Aurora SNU in, I think it's down in Tucson. But last I checked, there was essentially one hospital where you could send someone who's diagnosed with autism, regardless of whether or not autism is a contributing part of their presentation.
Okay, so do you see, Dr. Babbitt, then, is autism a barrier to admission? Like, let's say if someone wanted to get admitted to the PAC or FMC, if they have an autistic spectrum diagnosis, that would be an exclusion? Yes. Okay, I had not seen that. I don't know. Is that something that you guys have seen too? Yeah, okay. Thank you.
My son is an alcoholic, and this is in Louisiana though. He goes to rehab, and he'll go like 30 days, and he'll be willing to go to 30 days, and then he leaves. He's gone to rehab like 3 times. When he leaves, discharges, then he's back in the same community with the same people, and he's doing back what he's doing again. So is there some word you follow afterward and like keep him, not him, a patient on track to where they don't backslide?
Yeah, right.
And then sometimes they're court ordered, and then it's like, how do you get the court to make sure that the patient is being monitored and encouraged to not go, slipping back into drugs and alcohol,
Right. So 2 good questions. One, I know when Kelly's up here, she's going to talk about the SARP program, which transitions to what's called the IOP. And I know these good folks mentioned it too, intense outpatient programming. So the idea is when someone leaves, they should have a wraparound supports for outpatient services. Of course, it's dependent upon the person's motivation. So you also talked about the legal system. I work with the courts here a little bit, and we have something that's literally just called drug court. Drug court is if someone is facing a primarily substance-related crime, such as public intoxication or a DUI, part of their court mandate can be, hey, if you're in drug court, you have to stay adherent with the outpatient recommendations. If you slip up more times, I think 3 times, then you end up getting locked up. So essentially, it's a punitive measure that's intended to be therapeutic, but at the end of the day, there's kind of a hammer over their heads. So sometimes, having someone on probation, even though we don't like people on probation, is like sometimes the best thing, because you need those 6 to 8 months of sobriety to get a sense of, oh, my life is better. The other thing that's worth commenting is that there are medications separate from that buprenorphine that can help with alcohol-related disorders. There's a shot that people can get once a month that tends to decrease cravings. 2, there's a pill that you can take 2 to 3 times a week, which will make you very sick if you drink alcohol. And a lot of times people don't like to do that because you get really sick if you drink alcohol. It's called disulfiram or Antabuse, and you can take that too. So sometimes medications can be used to help that, and also the legal system can be used to sort of mandate, force people into treatment, which can be outpatient programming, typically 4 to 5. How long is your IOP? Is it 14 months? Okay. And how many times a week?
Yeah, and I'll talk about this in outpatient as well, but we have 5 phases. It's about 14 months. Phase 1 is 3 groups a week, generally 2 to 4. We have one class that goes a little bit longer. Phase 2, you have 2 groups a week. Phase 3 and 4, 1 group a week. They are checked by surveillance officers. They could be tested at any time, swabbed to see if they're under the influence, if they violate curfew. Showing up to group a minute late, we don't let them in. They're sanctioned. And sometimes when they go back into jail, when they're sober, it's a much different experience, but it's a very therapeutic process for us because we understand relapse is a part of recovery. And when they're honest with it, the judge often works with us, works with the team to come up with, is it just community service? Do they need a weekend in jail? Do we need to send them to residential? It's not if you mess up and relapse, you're out of the program. We're very understanding that that is a part of the cycle. We, I think, do a very good job with that, offer a lot of resources for the individual. And as Dr. Linsky pointed out, they can choose to be with us or not. They could choose and say, I just want to go to jail, serve my time, go to prison. They're facing felony charges. Completion of our program will result in their felony charges going down to misdemeanors. Their community service, their attorney fees are waived if they complete that. So it's very good for the person if they want to do that. Many have been in the jail system and went through the Exodus program, which is a very awesome program for those individuals. Very, very structured, very amazing. We work well with them. Many of those clients are in jail. Then they'll come to us when they're released as a contingency. They'll plea into our program. So.
Yeah. Oh, my name is Mike Lillo. I'm over at the Flag Dorm. I've been there for about nearly 18 years now, and as a counselor, been in school psych for the first part, then I just ended up over there. Appreciate it. A lot of kids. Usually we have upwards of 160, but we have right now we have about 100. But what I'm seeing is a lot of medication through vapes and for anxiety. And the dorm is kind of a setting home away from home. They tend to flag high, and because of their self-medication, there's a lot of we eventually catch them. This comes spring, when spring comes about, things happen. So I think the last time I seen like a almost effective approach to it was when Coconino High School was offering that program where they would be referred to them for like about the morning, like 8 to 12, and it had discontinued. And sometimes Dean Howard, our Howard over at probation, was kind of doing the referral for that, along with Tony Collin from Flagstaff High School. So it's kind of a triangulated collaboration type deal. But since it has kind of ended, and for the most part, we try to go through NACA, we go through Child and Family, and we haven't been to Guidance Center yet, but we know that's available as well. There's a few alcoholic type situations, incidents that occur, so it's really acute. It's not much of a deal, but it's the self-medication through vaping and trying to like help themselves and not having that maturity, I guess, to say I need help. High school kids will not typically do that in our setting. Yeah.
Folks during that networking I met, was it Sammy that works with works with the programming for tobacco use? That's you. Oh, look at you putting your hat in there. Oh, wait, you do. Yeah. So is that resonate with you, what he's saying? Because he's out at the dorm. Do you guys work with that population at all out there or no?
Yeah, we offer or help facilitate two anti-tobacco youth coalitions that are I would say very small. The amount of students who want to be actively involved or choose to be involved in an anti-tobacco coalition is small. We are hoping to be able to reach more students. We're applying for another grant to kind of widen the substances that we're able to talk about and just offer a broader range of prevention activities. So less like come join our club and do a bunch of work and hopefully offering more just after school programming, because we know that like supervision and structured time and connection is helpful as a prevention strategy. But yeah, we do see a lot of people. We've had like 3 elementary schools reach out to us in regards to students vaping. We're just kind of in a tricky spot as like because of the way that we're funded, we're not technically supposed to do a bunch of direct education, unfortunately, and so kind of have to work in really roundabout ways. But hopefully through wider services, if we get this grant, we can do more work and engage students who are using substances, because generally that's not the students that we're seeing in our clubs. They're kind of already, I don't want to say straight edge students, but a little more health inclined and tend to be students who are already getting a lot of support in a lot of different ways.
So for your issue, just to address it, like who does anyone here have an idea of how to support that population in terms of decreasing or getting access to services for substance? I mean, because the thought that comes to mind is I'm always like, well, we could probably do something. I mean, we have our director of clinical director here, Dr. Babbitt. So I my thought would be like, I wonder if we could engage through the guidance center doing some services out there. I see you shaking, you nodding your head. You're in trouble right now. You're agreeing to something here. Look at that. So I don't know, I'm just curious because you bring up a really valid point, because a lot of times that's something that we don't really worry about. It's like, oh, well, at least they're not using fentanyl, they're just vaping. But in fact, that's also very dangerous in its own way and needs to be addressed. So I hear what you're saying. I don't know how to support you except to say that I agree with you. And if there's someone that has some idea how to get services, or, if this is, if as a community partner, we're hearing this, maybe that's something that we could set up through the guidance center if there's a way we could do it. I see you now rubbing your head, Dr. Babbitt.
I love this connection that's happening right here. And this is the reason that, we wanted to get everyone together today so we could make these connections and start these collaborations. We are going to, I'm getting the wrap up signal from Steve that we are going to move on to our residential panel. We will talk more about outpatient services a little bit later. And so I really want to come back to this discussion that we're having right now. I did promise one more question here. It can wait till the residential. Okay. All right. Good. So at this point, do we have a little break? Are we just going to? Yeah.
So we're about 10 minutes behind schedule on this one. How about a round of applause for our inpatient folks? If we can get our residential folks to come up here, we do have lunch that's going to be ready. We do have 30 minutes at the end of the day that is geared towards having these conversations. So if we could get our 2 panelists for residential services to come on up. Kelly, you too, please. So sorry, tremendous conversations, of course, but we have a lot of other information we want to share and get across to. So we may have to eat and talk here in a little bit as well, if folks are okay with that.
Thank you guys so much for being here. Could you go ahead and introduce yourselves? And you don't have to stand if you don't want. You can sit if you would like. Okay.
So I am, again, Kelly Gonzalez with the Guidance Center. I run the residential programs there, doing program management. We're here for substance use, so that's what we're going to focus on today, is our substance use department, SARP department. So if I say SARP, you guys know what I'm talking about. Stands for Substance Abuse Residential Rehabilitation Program. It's a lot, so you don't have to remember it. You just remember SARP. I've been at the Guidance Center for about 3.5 years. The Guidance Center is actually what brought me to Flagstaff. So yeah, I look forward to all of your questions and connecting with you guys.
Hi, everybody. My name is Samantha Nixon. I go by Sammy. It's a little less formal. I work for Crossroads Inc. We're located in Phoenix, so not Flagstaff, but down in the valley. We have residential, outpatient, IOP as well, but I'm sitting on the residential. I'm currently the administrator for the outpatient program, but I have about 4 years of experience working on the residential side too, so I know quite a bit about all the levels of care. I'm also a alumni of Crossroads, so I graduated there in 2016. So I have the personal experience of going through residential and IOP there. So I'm happy to answer any questions that you have as far as the experience and what is lacking or what could be better. So currently I am an independently licensed addiction counselor. I have my master's through GCU, and I'm actively working. I'll be graduating in about a year with professional counseling. So I decided to expand my scope of practice after realizing how complex addiction is and what really needs to be treated in addiction. So yeah, that's a little bit about me.
Could you first start by talking about the difference between inpatient services and residential services versus IOP and outpatient services, and just really define what residential services look like?
Yeah. Can we just give Sammy a round of applause? Because I think that it's really great that to share that, just with the group, just that's awesome. So it's weird for me to sit, so I'm just gonna stand because I feel I'm really nervous anyway. So
You're doing great.
thank you. So inpatient services, for our PAC unit, right? That's an involuntary program. You're behind locked doors. You don't really have a lot of choice about where you're that you're there. If you're there voluntarily and it's been deemed that you're too acute to then discharge yourself, you're going to stay there involuntarily as well. Whereas residential, I am this really sweet spot where we're inpatient, outpatient services. You live on my unit, and so you have to run my program. You have to go to my groups. You have to attend all of the extracurricular things that we're doing. But the doors are open, right? You can walk out anytime you want. Whereas IOP or your intensive outpatient services are going to look like you live at home, right? You're in the place that you want to be, not on my unit with my really super comfortable beds. But you're where you want to be, and then you're going to come in and you're going to engage in services through that program.
What she said. Yeah, I mean, with Crossroads, we don't have inpatient, so usually we're getting those referrals from detox centers. We do have clients come into our admissions office that are in need of detox services. They're assessed by medical personnel and determined to be appropriate for detox, and they will be referred to some of our partners that we work with to detox and then transported back to residential once they're cleared medically to engage in that level. We do administer medications. We have a staff member that helps them monitors their medications to make sure they're given at the appropriate times and at the appropriate doses, and they're watched taking them. But they are not watched over by medical personnel there per se. Crossroads does have clinic that provides psychiatric and medical assistance as well. But that is not on every residential property. So inpatient and detox is more medically monitored.
How big are your facilities and how long do people stay?
At the Guidance Center, the SARP unit, we are a 16-bed unit where we have 7 double occupancy rooms and 2 single occupancy rooms. We start out a 28-day program, and then we extend services out to 90 days. If I can talk insurance companies into letting me keep people for longer for like one reason or another, I do my very best to keep them as long as I possibly can. I think that the longest that I've ever like finagled at insurance was 97 days. So it's like we did really good. I was really excited. And yeah, and so it goes with the it goes with what the member is ready to do, right? So like a member comes in and they're just like, I'm only going to do that 28 days. And if it fits and if it's feeling good and they want to continue that, they can, instead of going in somewhere being like, I have to do 90 days and feeling like it's this big drag on them. Like it gives them choice, which all of us are doing something within the mental health field. And we all know that choice definitely increases, right, buy-in. And so, yeah.
So Crossroads currently has 8 residential facilities. 7 of them are men's and 1 women's facility. I know but the referrals just don't come in. I think there's some barriers to definitely look at when you were talking about some things to look at. With the residency, I think women in those need for help with child care or even pregnant, I think there's a bigger stigma around women struggling with substance abuse. So I think that is maybe contributing to it a little bit, but it is a large facility. It does house up to 102 women all in one, but it's a very quaint community and everyone kind of works together. What's unique about Crossroads, it is a peer company. So it is ran by people who are in recovery and have that shared experience. Most often it is people who complete residential and then do the levels of care and then come in and get peer support certified and work and they are alumni. So they have that experience of knowing what it feels like to sit in that chair. And that is very comforting to some of the people coming in to receive services. So, yep. So that is how it goes. And then we have 4 outpatient programs across the valley that all have different kind of niches to fit clients what they're looking for when they leave and that discharge planning. So we've kind of developed a unique way of that transition and fitting them and meeting them where they are.
Can you talk about pregnant patients?
Sure. So Crossroads does work closely with CMS, which is a methadone clinic, and Hushabye Nursery. If you're not familiar with them, they're fantastic. So the idea is we do have also a nurse practitioner that is a women's nurse practitioner that will monitor them and support them through that process of pregnancy, or even if they're postpartum and they just recently delivered, it's a huge support to have that psychiatric and nurse practitioners specialty with women. But we will establish care with them, help them get on methadone, as that is I believe it's the safest way medication management to be on while pregnant. And then we connect them with Hushabye Nursery, which actually they're very supportive of the birthing process. And then instead of the baby being in the NICU at the hospital, they can be in Hushabye Nursery with their mother and be able to receive that support, mother and baby and family. So they prep the parents with education and they, go to classes and get car seats and all sorts of resources. And they really support them through that process. And if they have a DCS case, they're working closely with DCS as well. So that's how we support women.
What she said. At the guidance center, and I'm just going to stand up because I'm going to call on you, Dr. Babbitt. We do have, of course, we take and we treat pregnant mothers expecting on our units, but we do have a special program, Moms and Babies, that we work closely with through just it's a program that we have. If you want to expand on that, because it's not my.
I think if it's okay with you, I can chat about that when I talk on the next panel, but Kelly is absolutely right. We have a special program called the Moms and Babies program. We also were awarded a 4-year grant through Arizona Complete Health through Access that is funded through SAMHSA that is specifically targeting pregnant and parenting women with substance use disorders. And so that if you are a pregnant or parenting woman with a substance use disorder, you then qualify for this program. I think Access called it Narwhal. We don't call it that there at the Guidance Center, but it qualifies you for a host of additional resources. But Kelly's absolutely right. Specifically to residential, pregnant women who are using substances are a priority admit for insurance companies, and we see them on the unit.
Additionally to the, other services that they're going to receive on the outpatient side, how I like to run this program is I like them to be as independent as possible, right? As I don't find the standard rehab process to be very successful. I don't want it to feel like they're incarcerated within my unit. And so if I have people with special circumstances, and being pregnant is definitely one of those things, we work closely with them, right? To make sure that they can go to doctor's appointments, that they can see their families through that we're connecting with those things all the time within the scope of what our program, can and cannot allow. We stretch it as far as we can. And sometimes, I just I'll get yelled about it later. It's fine. But definitely it's, everybody needs help. And so given your special circumstance shouldn't exempt you from getting the help that you need.
How long does it take to get into residential services? Is there a wait list?
Oh man, well that is very topsy-turvy, right? So sometimes I'm full and I have a wait list. Other times, if any of you guys are listening right now, I have beds available, so we can fill sooner. So basically what happens is our process, at least, you need to be part of a health home, whether that's with the guidance center or one of the others, Spectrum, Encompass, it doesn't matter, right? You have case managers there. They can send the referral into us. And we can get them in, depending upon insurance, it can be anywhere from to, a week to 3 weeks, depending upon what's going on and how fast the, insurance is willing to go. And if I can get all the documentation that I need, if somebody is wanting and they're asking for treatment, it becomes our jobs to ensure that they get the treatment as fast as they possibly can. Because as we all know, the idea changes, right? The circumstance changes very, very quickly. And so, at least for this department, we work very tirelessly to find the yes and find what it is that we need to do to make the ends meet, to facilitate programming.
Awesome. I forgot to mention our programs are 45 days typically, but same as you, insurance, sometimes, we have to fight for that, but we will fight. So with Crossroads, the admissions process is typically first come, first serve. They show up at the corporate office at 7 a.m. Monday through Saturday, and they get in that day. We typically have beds available, so it's very few and in between as we have grown that we don't have beds available. There are direct, you can coordinate care, and especially if they're coming from Flagstaff area, you can reach out and directly connect that. We also work with outreach and reach in. So we have a reach in program that goes into the jail system, and we'll actually screen people and talk about services. And we also work with federal pretrial. So we will have clients that are coming in waiting sentencing for pretrial receiving substance use treatment. And we also work with DUI drug court. So we are providing services to those who are currently on that endeavor and journey. And those ones will be direct admit same day. We'll call, they'll set up an intake, and we'll get them in when appropriate. As far as outpatient, our goal is 48 hours to get them from the time they call to the time they're engaging in their intake. That is the goal, give or take. But we don't like time to go by because lots can happen in 24 hours. So we want to, if they make that decision, we want to get them in treatment immediately. So we do whatever we can to make that happen. So.
Thank you. Can you talk about what resources you have for individuals who are uninsured or underinsured, as residential treatment services are very expensive and cost can be a barrier for folks?
We have SABG funds, right? That we typically go through. That criteria has gotten a lot harder and is probably one of the biggest barriers right now. We also work very, very hard to get people onto access one of the many plans. Our front office actually helps walk them through what that process looks like. And if they come on to the unit on SABG funds on the unit, we work really hard to then get them onto a plan so that we can then get another, somebody who has SABG funds onto the unit. So definitely I don't think that I have any other tricks that are anything. Maybe Sammy does.
I don't know if it's a trick, but we have a great community who likes to support, and we have scholarship funds. So our idea is, and our CEO does not believe in turning anybody away. If someone wants help, that's what they're going to get. And so they will hold funds for scholarships so that they can go through and receive treatment if they don't meet criteria for SUBG, I think it is now, right? Substance use block grant. They change it. Yeah. But I think I did a Relias on that just the other day. But yes, so they don't qualify for that. They're maybe coming out of state and they can't get on Arizona insurance yet. We will figure it out. We want to provide them treatment if that's what they want and need.
This is probably a question more for Guidance Center because it's related to a wait list. So you mentioned that insurance, that's one of the dependencies for getting them in. But otherwise, if there is a wait list with multiple people on it, what is your prioritization criteria? Is it just length of stay on the wait list, or are there other considerations?
So generally what ends up happening with the wait list is first come, first serve, depending upon obviously if you are an IV drug user, you get bumped to the top. If you're pregnant, you get bumped to the top, things like that. If I've had somebody if I have a wait list and I have somebody who has recently graduated our program in any one of the increments of the program and they have relapsed within a 90-day, generally I will bump them to the top of the list so that we can immediately get back into what this new behavior looks like, right? What these new routines look like, so that we can catch it. Right. So then maybe it's only another 28 days that it takes for them and they're not out of life, doing programming like this is amazing, right? The part about it that makes it really tough is that I can't contrive enough things to emulate what real life is like. And so it's a bubble, no matter how many things that I put in there, because, you know, like I actually like our weekends, there's one group and they're like, we're so bored. I'm like, I know. I do it on purpose. I want you to be bored. You have to cope with it. So when they graduate, it's a whole different game, right? And as much as I can like speak about it and try and teach that, it's a whole different game. So I really like to get back in and dig back in with them and like, what was the relapse? Why was the relapse? What was your thought process? So then we can continue. And if they missed a step, like we, you know, Dr. Babbitt will talk about the IOP, or, you know, we also have a matrix program. Like, why didn't you engage in these services, right? Like you had these step down opportunities, and what about this did you not want to engage with, so that we can really get down to the nitty gritty of what's happening with them.
So I think that's time. I think, are we 11:45 lunch?
Yeah.
I would like to, while they're figuring that out, I would like you guys to know, like, I'm on the county's Hope Coalition, and that coalition is dedicated specifically to youth with substance use. You know, we have identified that obviously Flagstaff is you can't go to the gas station here without like there's a liquor aisle in every gas station for whatever reason. It's really weird. But so I would like, you know, you can reach out to me and I can get you in contact with Candace, who is the person who is like facilitating that coalition, to be a part of that if any of you guys are like interested in that, because you know, substance use and youth in Flagstaff is greatly underserved, and it is definitely a passion of mine to, you know, get it early. Like it's cool I can get it, you know, when they're older, but I would love, you know, for more of the community to come together to kind of nip this early. And so just so you know, especially with the dorms, I'm on lots of different sports boosters, and the dorms are like, they come with their own unique issues. And so I just wanted to like put that out there for you. So it was on your radar.
And I guess it's a question more of a comment, but the work that you both do, the work that everyone in this room probably does, is really amazing. And so I know we talk about a lot of the services that you all provide. How do you take care of yourself during this time? It's probably one of the most challenging jobs in the world, I imagine, but are there resources that you can take advantage of to kind of step back and be like, all right, my own mental health here, I need some help. I'm going to get back into the game? Because yeah, what you do is incredibly important, and I hope none of you burn out with any of this, because it's we really need all of it.
That's a great question. I think that compassion fatigue and burnout are huge. For me, myself, I'm in recovery. So even more important that I'm focusing on my recovery and making sure that I'm doing what I need to do. And that encompasses 12-step programs, community supports, really building that community. We're social creatures, and we need to have people around us with like-minded goals. And I surround myself with that. But nature and hiking and being able to go out and run. And I just did the rock and roll 10K in January, and, you know, get out there and just live your best life. It's about shifting your perspective and being able to enjoy the small things, and take time to smell the roses. But self-care is definitely something that we push very hard on our staff. In fact, I love to go around to all the different programs and just sit down with them and grill them about their self-care, because I need to make sure they're okay too. So we can't give what we don't have. And so it's super important.
I recently bought a hot tub. So if any of you guys are thinking about it, it's totally worth it. I'm just letting you guys know that right now, especially when it snows. It didn't snow all year this year, basically, but I know it's going to be great next year. I'm going to just kind of piggyback off of what Sammy said. Making sure that you have a good work-life balance is obviously the biggest thing. Dr. Babbitt actually is my go-to because she will literally chase me off of campus if she sees that I'm working too many hours because it's very easy for me to just like do that. For my staff, and it gets me in trouble sometimes just because of call outs and things like that. My staff are not allowed to work 5 days. They work 313s or they work 410s. So they have long extended weekends so they can give what they need to give with any of our clients on any of the given days that they're there. Yes, it's longer days, longer hours, but I find it to be more stabilizing for the unit as a whole if we're working with the same person throughout all of the, the ups and downs of the day. We also, for that, the Guidance Center and my units specifically are partnering with, they're called One Small Step, and they're a peer support program, and they're available to clients, and not only clients, but they're also available to my staff in the evenings, 7 days a week, so that they can call in, and if they're having an issue or they just need to talk, like they have that outlet over and above, nobody wants to like go get mental health services where they work, right? Because like we all know each other and we see each other at the staff meetings. And so it gives that secondary, pulled back third party for staff to engage in. Yeah.
That's wonderful. I love hearing about the supportive environments in which you work. Any other questions? Or just a lot of hunger, maybe. So I want to thank you guys for sitting on the panel. I know it's daunting to sit in front of a room full of people and speak publicly, but it's just so clear how passionate you both are, and the energy that you bring to work every day. I mean, it's very clear. So thank you. So a round of applause for them, guys. So at this point, we'll go ahead and break for lunch, and then we'll come back after and continue with this energy. We'll talk about outpatient services, and then we'll do a little bit more networking. All right. Great.
Hi, folks. We are, continue to finish your food and desserts and drinks as we go, but we wanted to get moving on with our panel. We've got about 55 minutes to an hour with this panel. And so, yeah, sorry, it's always rushed. There's always so many things to talk about and share and present and not enough time. We could do a week on this, as Cindy had mentioned. But anyhow, so we'll turn it over to Jen to kind of get us through this next panel. And thank you all for being here. Hopefully you enjoyed lunch.
All right. So thanks everyone for sticking around past lunch for our afternoon session. So this is going to be our outpatient panel. And I think I'm most excited for this because I'm looking forward to the connections that are going to be made this afternoon. So I guess let's start with some introductions. You want to go ahead and start?
Hello.
Hold
on. Ooh. Hi, guys. My name is Jennifer Georges. I'm the Senior Director for Crisis Services with Taros. I oversee mobile crisis for Mojave, Coconino, and Maricopa County. I've been with Taros for about a year and a half, and I actually started my crisis work or my introduction to crisis with Phoenix Fire Crisis Response Unit. I was with them for about two and a half years. And then I transitioned into more of a behavioral health field. I do have my MSW, Master in Social Work, and I am all but dissertation for my doctorate in behavioral health. And hopefully, fingers crossed, this year, I will officially be done with that. It's been a fun ride so far. But yeah, I'm Jen. People call me Jen G. There's a lot of Jennifers. So very nice to meet you guys.
Hi, I'm Kelly Brown. I'm the Northern Arizona Clinical Director for Child and Family Support Services, and we cover Flagstaff, Prescott, and Mojave County for kids' behavioral health services, and I've been there for 15 years now.
Hi, Todd Parker. I'm an LPC licensed professional counselor. I work at Flagstaff Medical Center. I oversee our inpatient, as talked about earlier, but also our outpatient. I think we'll talk about those services in a minute, but I've been there 30 years and We have a small outpatient practice, but we'll talk about that.
Thank you. Hello, my name is James Danella, I'm the young pup of the group. I'm a licensed associate counselor from Southwest Behavioral and Health Services, and yeah, you're just taking Dr. Lowry's place for today. Yeah, I've been there at Southwest for about 18 months. I began as an intern, did my full internship there, and then have been a therapist there for about a year now.
I am Dr. Stephanie Babbitt. I'm the Chief Clinical Officer over at the Guidance Center. I too have not been around here for 30 years. I've been back in Flagstaff for 5, and I'm here to talk to you about the options at the Guidance Center that are not inpatient or residential. I'm also a licensed clinical psychologist, so I see people as part of an outpatient practice at the Guidance Center, a forensic contract, but serve as the CCO at the Guidance Center. And I need to make a joke that I feel like the only reason I was invited is because Steve and my sons play hockey together.
The connections we make in this town are amazing. Poor Sara got roped into talking today because we're in book club together. So Chris Linsky, I don't know if Chris is still here. He coached my daughter's soccer team a long time ago. Anyway, lots of connections in this town, that's for sure. So, could you start off talking about the services, the outpatient services that the Guidance Center provides?
Yes, I actually made notes, not because I don't know what they are, but because we provide so many. I also want to start off and kind of mimic some of the things that Dr. Linsky shared. The Guidance Center provides a full spectrum of services from all the way from inpatient down to outpatient. But we've been around since 1969, and since that time, we've tried to develop programs that meet the community need. And so I was very touched by Chris kind of reaching out to the crowd and saying, what is it that you think that you need? Because the Guidance Center is really in the habit of trying to fill any gaps that exist in our community. Let me look at my notes. So as you know, and we've covered, we provide an inpatient psychiatric hospital. One step down from that, we have our crisis stabilization unit where individuals who aren't meeting hospital criteria can go for up to 24 hours. We do MOUD and MAT services there. One step down from that, and I think is a highly underutilized resource, is we have a 24/7 crisis department. At the Guidance Center, we really pride ourselves on serving individuals in Coconino and surrounding counties, regardless of their ability to pay. And our crisis department is a perfect example of that. Coconino County actually pays for those services through the Guidance Center. But what I like about it is that there's real humans that answer the phone 24/7 and real humans that you can engage in. And while the National Suicide Hotline is excellent and 988 in the state of Arizona is excellent, if you know someone who needs to speak to someone, they can simply call the Guidance Center and there will be someone who answers the phone every single time, or they can walk in and see someone. We have 2 residential units. I'm including everything because they are considered outpatient per licensure. One for individuals with serious mental illness and one for individuals who are struggling with substances. We have an assertive community treatment team, an ACT team, which is a pretty unique model where individuals are interacting with their care team 4, 5, 6, 7 times a week. We have a court-ordered treatment team because we're also involved in court-ordered treatment on an inpatient and outpatient side. We have a variety of special programs that range from birth to 5, youth in transition. We have a center of excellence for autism spectrum disorders and first episode psychosis. We have a moms and babies program. And as I alluded to before, we have a grant for the next couple of years to serve pregnant and parenting moms with substance use disorders. Oh my goodness, we have a lot more. And then we have a typical outpatient menu of 20 to 30 groups a week. We do psychiatry, psychology, ABA, counseling and therapy, vocational coordination, and peer support, in addition to other things. And I'm going to pass this along.
Thank you. So yeah, at Southwest Behavioral and Health, we kind of function as a health home up here. So we have clinics kind of all around the state, a lot down in Maricopa County, but up here, kind of try and work as like a one-stop, kind of serves all as much as we can. So we're like an outpatient facility. We offer individual counseling services. We offer group services for both people navigating like substance use issues. We have substance use groups, Monday through Friday. We offer domestic violence groups as well. We have peer support, vocational, assistance, offer med management. We have a really awesome provider team. Our psychiatric nurse practitioner there is awesome. We also have a psychologist on staff who does all of our like autism and ADHD testing. So we offer all of our like outpatient services here, but then we also work with all of our other clinics. So if people ever need any like residential resources or anything like that, we're always coordinating with our facilities and just trying to get people the help that they need. I think that kind of covers it all, and I'll pass it on.
Hi. At FMC, we offer a variety of outpatient services, not as robust as the Guidance Center or Southwest or my colleagues to my right and left. We do have a small clinic with counselors that serve our NAH employees with EAP, Employee Assistance Program. They get 8 free sessions per year per issue. We also take insurance from the community. We have a couple providers that are licensed independently that can do that and bill insurances. One of the challenges that we have is we're not a Site 11, we're a Site 22. We're hospital-based, which the paying structure is much different, comes out of deductible versus copays. We are actively working to try to change that. We got our primary care clinic up and running, licensed for behavioral health. We want to extend those services there. We have 3 psychologists. One works remote, does a lot of groups, weight management, DBT, other groups like that, sleep group that she works through the primary care clinic, NAHMG, which is now up on the Mesa. Dr. Martin also does some integrated care both in the Verde and the Flagstaff area. We now have a resident, if you will, for psychology. She is a psychologist working with us, going to be start seeing some patients within our community. We are working to get probably, I would say late December, a psychiatrist for a very small outpatient service that's sorely needed. We haven't had outpatient psychiatry in quite a while. Additionally, we have one counselor who does see a variety of insured and EAP clients, but also works with our children's health services through the VOCA grant, Victims of Crime Act. She specializes with trauma for young kids. She doesn't do the littles, but generally 10, 11 on up, she can work with those individuals. We also have a TMS machine, transcranial magnetic stimulation. That's been very successful for us in lieu of, like Monica mentioned earlier, ECT. Those that are struggling with depression, it's also approved for OCD currently. Those treatments are 5 times a week. They're about 20 to 30 minutes long, 5 times a week for 5 weeks. And it's not as invasive as ECT under anesthesia, et cetera. Lastly, we're very proud of our recovery court program also. I think someone mentioned a DUI drug court. Here it's called recovery court. It's about 14 months long. The clients plea in for that. We offer a variety of modalities. We do, I think I mentioned yoga. We do CBT, DBT. We got ACT trained therapists specific for substance use. We do motivational interviewing, of course, work through the AA model, recovery. And like I said, very forgiving. If people relapse and they're honest, we had a gentleman just the other day that did so, and the courts were very generous and offered him residential instead of being kicked out of the program. We have a great relationship with Coconino Court on this. Judge Reed is the primary judge. He is awesome to work with that team, and we try to get as many of those folks in as we can. Majority of them have numerous legal charges related to substances. I think as mentioned earlier, DUI, DV, public intoxication, any sundry of items. They're facing felony charges, so it's a good program for them. And we have about an 80% graduation rate with that. We're very proud of that. So.
So as I mentioned, we're Child and Family Support Services. We're hiding over behind the Cedar Safeway. There's a small unknown building back there. Typically, we serve anywhere between 500 to 600 kids from the Flagstaff area. We serve Medicaid only, so really focused on low-income kids and families. One of the things we really focus on is trying to create new opportunities for kids. So getting beyond diagnosis and all the trouble some of our teens get into, and really serving them through strengths, talents, and opportunities. So really trying to get out in the community, expose kids to new experiences. So we're on hiking trails a lot. We have a music recording studio in our office to try to capture talent. Do a lot of art shows. We also have some great community partnership with like the Flyers mountain bike program and Grand Canyon Youth. We get out on the river in the summer, try to do a lot of outdoor activities, and really see that as a part of creating change in the Flagstaff community is through all of those partnerships so that kids can experience new things. The best part of treating substance abuse issues is creating competition for use. And so really targeting how do we get kids doing things other than using, exposing them to new opportunities, and that's a big part of what we do. We also really focus on family systems and really looking at how intergenerational trauma affects kids and families. And so if we just target a kid, they're still going back to the same family system and the same struggles that a lot of our families face when they're dealing with poverty, lack of resources, and trauma that their parents have faced. And so it's really teaching family systems new skills to really thrive and do connection-based work. So we serve all the way from birth to young adulthood, and really try to individualize programming based on what kids' unique experiences are and really individualize what their care looks like. Sometimes that means really intensive care, and sometimes that's real traditional counseling services, psychiatry. For our really high-need kids, we may be going into schools and doing really intensive wraparound services to get kids successful in school, making new friends, being successful in the community, getting jobs, and I love it. It's really fun to get out there and do things with kids in a different way.
For Teros, our main site here in Coconino County, we do our mobile crisis unit. Within the mobile crisis team, we have a 911 dedicated team that gets dispatched through the PD, dispatching with Solari. We also have our care team, and we are working on the new contract amendment with the city of Flagstaff. It requires us to start hiring our own EMTs. So we're going to start working on bringing on EMTs along with our BHTs with the unit. We're also working with the city of Flagstaff to start our downtown ambassador program. So we're going to have a crisis specialist pretty much like patrolling or walking around the downtown Heritage Square area. And they're going to be providing support to anyone that is needing substance use, substance abuse, anyone experiencing homelessness, anyone that is lost or needs additional resources or guidance. They will be working closely with the care team to provide transportation or additional resources or support. They'll also be working closely with the Downtown Business Alliance in case there's any individual that goes into the business. Instead of calling police, they'll call our ambassador to help reduce our recidivism of getting incarcerated and or arrested. In addition to that, right now we are also working with the NARBA Institute. We're going to be hopefully in the next couple months working on bringing in Alliance Coordinator, which will work hopefully closely with a lot of the hospitals to be able to do a 7-day post-hospitalization assessment and help them get connected to a behavioral health home. Outside of Coconino County, in Mojave and Maricopa County, we do have, I don't know if you guys have heard of it, it's Crisis to Recovery or our aftercare program. We're working to duplicate that here in Coconino County soon. It'll be a crisis to discovery. So anyone that is getting discharged from outpatient services, anyone that's getting discharged from incarceration or needs additional resources or post-crisis intervention, they'll be able to follow them for a period of time to help them get documentation, especially if someone that's lost their birth certificate, social security card, driver's license. They need that to get an apartment. They need that to apply for a job. They need support with transportation to and from any additional appointments. We'll be able to help close that gap a little bit more. So we're going to be working on not just the crisis intervention itself, but also post-crisis. So we're hoping to bring that here to Coconino County soon. And then in Mojave and Maricopa County, we have a lot more services available to the community, from primary care to continual therapy and support, and of course, mobile crisis down there as well.
Wow. We are a town of what, 76,000 people, 80,000 people. And to be able to offer, this breadth of services is impressive. Just listening to all of you rattle off, all of the services you provide. Wow, I'm overwhelmed. Could you all talk about your successes and programs that you are interested in perhaps creating in the future?
Kind of mentioned a little bit about that as well, but one of the big successes that we've had within the crisis team came out of Mojave County, which is a crisis to recovery through the opioid grant. And it started March of last year, and it completely took a whole life on its own. Within the first day, we received about 13 referrals. And then from there, we're continually receiving referrals consistently. The aftercare team, which is similar to that in Maricopa County, we receive about 100 referrals a month for anyone that needs that support. And with that, we're noticing the gaps in the services that are needed here as well, which is why we're working very closely into being able to duplicate that here in Coconino County and being able to work more closely and have better collaboration relationship with everyone in the community. I feel like the crisis team has those avenues to everyone, from FNC to TGC to Southwest to every single community here, that we want to make sure that we are meeting those needs. And we also want to take the feedback to, what do you guys feel that crisis needs to work on, improve? We are doing a whole restructure right now. There has been some changes within our crisis team here. We did switch over, so instead of a director here, we're going to have a regional manager who's going to be able to work more closely related to the community to help close those gaps and being that avenue between hospital to behavioral health home to residential, and help close those gaps as much as possible.
I would say our community partnerships are the thing I'm most proud of, because I think that's how we create change for kids. Is they can't just be served through one system. We really have to look at holistic care. So we meet regularly with Flagstaff schools. We meet regularly with juvenile probation, child welfare, developmental disabilities. And I think the richness of those partnerships in this community really goes a long way to be able to really wrap services around kids and families and help overcome barriers that any one system may be stuck on. Being able to come together to create change is really an integral part of what we do. And being able to work across communities has been interesting, because I don't see always those same relationships in other communities. And you can really see where things get stuck in court systems, in not knowing who to call. So I think building those collaborative relationships is really key. And I think Flagstaff is really ahead of the curve on that. We can call over to probation and get in front of a kid in the detention center. In other areas, we may not be able to get in to see a kid that is incarcerated. And really being able to outreach, to go into classrooms, to really go across systems is really core to what we do. I think other natural relationships, like I mentioned, Grand Canyon Youth and the Flyers program, I think getting kids and families access to more of those things, affordable opportunities that a lot of our families don't have access to, is incredibly important. And we still have a long way to go in that arena through scholarships and other opportunities to martial arts, working out, arts, music, to really make sure all of our kids can excel and have the opportunities that would help them thrive. So I'm really proud of those partnerships, but I think we can use more as well to really create change for our kids. And I think that's all I'll say for now.
I think one of our big recent successes is getting an addiction psychiatrist down in the Verde Valley area. I wish we had one up here, but it's a partnership with that and our therapist down there that's an addictions therapist. Again, slowly trying to build that. And I'll piggyback on what you said. I think the collaboration, everyone to my right and left, great partners. Whenever we need appointments within 7 days of discharge, it's amazing how quickly we do that. We have very few that are just past that. And it's so critical those first 7 days after discharge. We'll call over Guidance Center, Southwest or CFSS, and they will get them in very quickly. And also kudos to NAU. They have a liaison for us for NAU students going back, coordinating those services. We also work with FUSD. When our kids are going back to school, we work with Nan Schoaf and some of her team at FUSD to share with them, when the parents permit, their safety plan. They help integrate them back into services. Here at NAU, they'll see if they need to continue. Do they need to take a break off from that semester? And it's those partnerships that keep our patients safe. And I wish we had the extended services as Guidance Center, some others do, because it's sorely needed. And I think just a small amount of psychiatry that we can offer is just huge in this area. We definitely need more, but we appreciate all the work that they do.
Excuse me. So I think I'll probably have a different answer than everyone else up here, as you know, I don't really have I understand the programs, but just because of my position, I don't view it from like a programmatic standpoint. I'm viewing it much more like as a clinician. But I think what, Todd was saying is something that I think is awesome and something that I've been really inspired by, which is how all of our different organizations kind of work together and come together to support, a very dynamic and wide-ranging community. And so I think, that's been very inspiring for me to see. And then also I think a big success for us has been like our opioid replacement services clinic. And of course, there's always chaos involved with, working with methadone and Suboxone and all this stuff. But I think it's really, I've just seen it have a very large impact on people and their recovery and, changing their identity away from, maybe someone who was, a heroin addict or fentanyl addict and, starting to view themselves as them, and not viewing the addiction. And then something that I've been thinking a lot about that I think is important is like adding additive curriculum to our substance use groups. Like a lot of our members deal with contextual factors, like as far as finances and navigating other community resources that they don't maybe have a ton of education on. And while it's important to, address the substance use, we also want to give people a stable platform to stand on so they can advocate for themselves and, kind of build that life as they go into recovery and kind of learn to maintain sobriety. And so, yeah, I don't know. That's something that I've been thinking about personally for our program and kind of learning to add that in to further support our, substance use members.
I want to mimic and echo the sentiments of the other panelists. I think Coconino County is very unique. I think that we all do a really nice job of working side by side and with each other every single day, along with NAU providers in Phoenix, all of the other entities that aren't represented up here. I think that relationship, I've at least observed it grow and change for the better over the last 5 years that I've been back up here. And I feel like it makes the world of difference for folks. I think a TGC, the Guidance Center Victory, that we're really proud of this year, we've brought on 2 new intensive outpatient programs, one for general mental health and one for individuals with substance use disorders. That has been almost an immediate success. And so providing a level of care that we hadn't provided in the past and have it kind of take shape so quickly has been really nice. We also are planning on opening a respite, a facility-based respite this year, primarily for children to, again, fill a gap that existed in our community that we're trying to fill. So that's my response.
Wonderful. And you bring up a good point. We have so many people here today that aren't on this outpatient panel that are providing services in the community. Do we have anyone here from NAU, Counseling and Testing Services? Wasn't sure if anyone from NAU was able to be here today. Are you here from NAU? Yeah. Could you talk a little bit about the outpatient services that you're providing?
Good afternoon. My name is Lee Yoshiyama, and I work here at the Institute for Human Development as a program manager. Our primary customers are the 93 tribes across the country who are providing their own vocational rehabilitation services for individuals with disability to go back to work. Our primary focus of expertise is education, training, and technical assistance. By far, the most effective modality is doing on-site. But we had to take a step back recently because of COVID, and some tribal leaders are still leery about outside agencies coming into their reservation. I like to think that what we do has had an effect on the employment outcome of our relatives with disabilities. We work with the programs in terms of helping them design what we call a culturally appropriate and responsive TVR model, where they look at their culture to determine if there's anything in their culture that could complement the VR process model from intake to a successful employment outcome. I've been doing this work for over 30 years, and so very familiar with the Tribal Voc Rehab program. They are also required to go into a memorandum of understanding with the state VR agency and are looked at as equal partners. So I believe what we're doing out there is effective and good. I don't know if any of the agencies do tap into that target population, and if so, what all are you guys doing?
We do vocational services for all individuals, but nothing specific. We don't have a specific program for tribal members.
I'm gonna echo that. Services for everyone. We work with a lot of tribal members, but nothing specific to that.
Yeah, same thing. A lot of our clients either are patients, inpatient or outpatient. We work with the variety of the tribes for inpatient and any community members in the recovery court program we serve. And so wish we had more resources for that from a vocational standpoint as well.
We don't do anything separate in that area, so it's more general services.
For us, we are growing and learning more. We do respond to a lot of nearby reservations, and we do have a team over in Hopi in Tuba City. So we are learning and growing more. We do want to provide more services. We do have a lot of our crisis specialists that are also voicing what they're going through, what they're providing into their same tribal communities to be able to, for us to be able to go in and provide more support. As of right now, the only area that we are in is in Tuba City, so the Hopi area, but we are working on wanting to grow more, especially in the crisis side and the crisis services.
North Country, can you talk a little bit about what North Country is doing in this world?
Hi, everyone. I'm Sara Coles. I'm the Family Medicine Residency Director at North Country. North Country is a large federally qualified health system that has clinics across northern Arizona. We are a comprehensive primary care practice, so we do pediatric and obstetrical care and everybody else in between, which also includes primary care for folks with substance use disorder, including medications for opioid use disorder and medications for alcohol use disorder. We largely do a home-based induction and maintenance model. So if you ever have folks who need home-based treatments, that is us. We are very happy to do that. And then a big part of our work is training our family medicine and soon-to-be psychiatry residents to be able to provide these services in our various communities and practice setting types.
And how about the health department? Is anyone from the health department able to come today?
We are from prevention. I do opioid overdose prevention. And just provide harm reduction services to citizens in our county.
And you want to talk about the MESA program?
It's not necessarily the MESA program. We're with Native Health. It's a community health center that's located in Phoenix. There's 3 centers located across the valley. We have a tribal all-text program that services 13 tribes in Arizona for case management services. We service urban Native Americans and some of the enrolled members from their reservations. It just depends on where they're from. In terms of outpatient treatment, intensive outpatient programs, and we mainly work with IHS facilities to ensure that those services are being implemented and making sure that there's aftercare once a member is released from outpatient treatment, intensive outpatient, or no, inpatient treatment, I'm sorry, or a residential program. One of the things that we're encountering that we're trying to overcome is the lack of services in rural counties. Most of these reservations that we service, they don't even have behavioral health providers. So most of them are stuck to traveling 4 hours just to see a provider. So that's one of the obstacles we're trying to overcome. One of the things that we're looking at is telehealth medicine. I know that the first presentation was very useful in that, and just trying to get those services out to these members. But Native Health, we don't necessarily do intensive outpatient unless they're court ordered. So that's like another barrier we're encountering. But yeah, that's what we're doing.
Wonderful. I won't put anyone else on the spot, but I'd like to pause and give anyone else that would like to speak up the opportunity to talk about the services that you're providing in the community.
Hi, everyone. So I am Sabbath Oliver, and this is Janet and Hema. We are from Yavapai County. We work for the reentry program. So we are located outside the jail. We have this beautiful building called the Connection Center. So when the people get released, they come to us and we connect them with services that mean, mental health, substance use, transportation, housing, or even just sit down and charge their phones, just a safe place for them to wait for their ride. We help the whole community, not only people getting released. Anybody that comes in our center will help them with connections or with resources.
I wanted to share two more things.
Go ahead. Yeah.
First of all, the Guidance Center just got funding for 2 additional harm reduction vending machines. I know some are placed at FMC and we have some at our county building, but the Guidance Center will have 2, one indoors in our main lobby, one outdoors by our crisis department. Included in those harm reduction vending machines will be fentanyl test strips, Narcan, hygiene kits, and bus passes, which hopefully will address a lot of the needs of our community. And I also wanted to mention that we do primary care in addition to all of the mental health services that we provide. A lot of this came as we identified a gap in that a lot of individuals that were coming through our doors hadn't seen a doctor or a physician or a provider in decades. And so we have one kind of family practitioner who can do primary care as well.
Wonderful. And I'll talk briefly about the emergency department. We also have Narcan vending machines located on our premises, including one outside of the emergency department, which is wonderful in that, people don't even have to go inside because the moment you're inside, you have to make eye contact and you have to talk to someone. So it's, it's great that we have that machine outside. The hope is that it lasts. This winter was kind, and so maybe we'll get another couple of years out of that machine because of that. In the emergency department, we have great help in resources. When someone comes into the ED asking for help for substance use, we evaluate them and make sure that they don't need to be hospitalized for alcohol withdrawal first, of course. But then after we determine that they are safe for discharge, sometimes discharge is not the right step for them. And so that's where we engage our mental health counselors. And we are fortunate that we have Todd's team that will come down to the emergency department, evaluate a patient, and offer them a list of local resources that a patient might be able to follow up follow up with. We also have Teros that comes into the emergency department as well, and does the same thing, and helps to arrange, those follow-up connections, which are so incredibly important. Myself as an ER doctor, I hate discharging someone what feels like the wind, right? I hate discharging them without a follow-up appointment, but that's typical these days. And so my next question to you all is, how quickly can patients get into your outpatient services?
For us, we can get people in right away. So we have plenty of capacity for intakes. Again, they have to be Medicaid eligible. We can help check eligibility when they call. But we can do intakes into our services right away. And typically, if they need psychiatric appointments following the intake, we can also get folks in for that right away as well.
For us, it's a little different. We don't really have that outpatient, but more if anybody does need to talk to someone, they can always call Solari. Solari will dispatch our team. We're 24/7, 7 days a week, holidays included. So if somebody does need to talk to someone before they get to their next appointment, my crisis team can get dispatched and provide those supportive services, help them to stabilize, help them with any crisis that they're going on through, or if they need to do another set of resource packets that could help them to at least make it to their next appointment.
For us, with our insured patients and outpatient, any given time, there could be an opening within a week or less, sometimes a little bit longer, depending on what we have bottlenecked. With our substance use program, it's a process through the courts. They will plea in, and then if they plea in on a Wednesday, we either see them that Thursday or that Monday, then they start groups immediately after that. Currently in the Cottonwood area with our addictions psychiatrist, she is wide open. We're trying to do same-day visits if they're in the emergency department there, to be able to even be routed over there during business hours. If not, the next business day is what the model we're trying to do, where they can get in quickly, be seen, be assessed, and start treatment.
Northern Arizona somewhere, can your addiction psychiatrist or provider see them over telemedicine, or are they only in person in Cottonwood?
That's a good question. I thought it was only in person, but let me check. I think initially they have to be seen in person to start some of that process, but I'll double check and get back with you, Dr. Gibson. I'll find out.
So, yeah, so like, let's say if it's someone who's already enrolled with us and they're being discharged from the hospital, or if like that's the situation, we can usually get people in right away. I think Todd kind of mentioned it earlier. When those discharge appointments happen, we try and make sure they're set up with their provider, crisis interventionist, as well as their therapist. So they usually have those 3 appointments set up. If it's someone new to services, it can, depending on the situation, be, like a couple of weeks, like 2 weeks to get into an intake, but we also do like DCS rapid referral intake. So there's definitely like a triage element to it. And depending on like the need of the individual, that can be expedited, to meet the needs of the person. But usually if they have been enrolled with us before, we can get them in right away. It might not be with their therapist, but it'll definitely be with someone.
My answer would say it depends on their insurance and what level of care you're pursuing. And so when Kelly was up here, she was talking about how long it takes to get someone on a residential unit. It is vastly expedited when you're coming from a higher level of care. And so coming from the ED or coming from our own hospital, we can generally get that person in to substance use residential treatment, or either or our other BRF as well, either same day or next day, because the insurance will expedite that review. On an outpatient basis, typically we can see people that same day, certainly the same week. The qualification with that is if the person has commercial insurance. So we take both commercial insurance and Medicaid. We have, I would say, 10-to-1 Medicaid providers, 2 independently licensed providers, which is what's required for commercial insurance. So if you have Blue Cross Blue Shield of Arizona or another commercial payer, that could increase the length of time it takes to intake you, but it's generally within 7 days.
So let's pivot a little bit. We had a lot of conversation happening earlier about outpatient services and needs from the local community. What questions do you have for our panel, or really for anyone in the room? And what needs do you have, or gaps perhaps, in services? We talked about nicotine earlier, and nicotine being a substance that's heavily used by youth these days.
I want to put Dr. Khan on the spot. She mentioned that they have, I'm really passionate about Suboxone provision and the induction, and that there be no wrong door. And one of your concerns was that administering take-home buprenorphine from the ED is that she couldn't find availability of outpatient providers to follow up with that patient. Is there anybody here who can help?
We can. The only, again, qualm with that is that they would have to be enrolled at the guidance center. So they would have to come in. We really do have no wrong door. You can find any of our lobbies. You can walk into our crisis department. Our crisis department is also our intake department. So they do a couple of intakes a week. There's a packet that they would need to fill out to get enrolled in services. We determine their eligibility and we plug them into the right provider type to get the prescription refilled and continued.
Yeah, so I can pick up on that as well. Very similar, they would need to be enrolled with Southwest Behavioral and Health, but we do have a on-site provider who works with our ORS opiate replacement services clinic. And so, yeah, we do have a setup where you can get someone, set up with a provider and can work with the Suboxone prescription, or again, also we have the whole methadone side as well.
Yeah, as I mentioned, Dr. Anderson and Cottonwood, I think one of the other challenges that we see is sober living that people can afford. When we all look at Maslow's hierarchy, there's no insight-oriented therapy when you don't know where you're going to live or where you're going to eat. We have some great services in town, in the Oxford House and some of the others, Hope Cottage. Some of those assisted facilities where they can stay are great. A lot of our people in recovery court are there. But in the first individual sessions, we're meeting with them as to where are you sleeping? What are you eating? Where are you getting your clothes? Some people, everything they have is what they brought out of jail in their backpack. So without those services, they're not going to go seek individual therapy. They're not going to do any of that. Years ago, we tried the Housing First project that posed its own challenges, where they would they selected a few folks that were interested and qualified, put them into Housing First. Unfortunately, it wasn't as successful as we had hoped, but I think there's where we can get a lot of resources for them. If they can be housed and get some services, we'll see a lot better success, especially with substance use. So that would be my vote.
I swear I'm a better sharer than this on a normal basis. We actually have a grant at the Guidance Center to provide housing assistance to individuals for sober living. So everyone who's enrolled with us can get up to $2,000 per member per year. It goes directly, we pay it directly to the Oxford House. And so that's a really wonderful resource that we've been able to help people find themselves housing. Also through the PPW PLT grant that I was referencing for parenting and pregnancy, parent and pregnant mothers, we'll be able to give even more rental assistance. Probably, we haven't worked this out with SAMHSA yet, but we'll be able to provide probably 6 months rent for the mom enrolled in our program. So they would have to be enrolled at the Guidance Center to get either of those things, but a resource that exists.
To go back to Dr. Gibson, when we have young adults that we serve, if they need specialty services, we do help connect them over to the Guidance Center Southwest for prescriber services because we don't do Suboxone or buprenorphine. And so we really try to connect there. For kids under 18, there are a lot of barriers for more significant use. And so we've had a couple of kids that were addicted to fentanyl, and it was really hard to find providers that will serve kids under 18 in that area. So we had to do a lot of work to connect kids and families out of Phoenix, and there were only a couple of providers that we found to do that. So I'd say that's an ongoing barrier for that real specialty area for youth. As far as other gaps, one of the big things I see is there's a real threat to Medicaid and health insurance for people. And I think that's going to be a big challenge for access to care in the future. There's a lot of threats to block grant dollars too. And so families that could receive alternative funding, if they didn't quite qualify for Medicaid, they can't quite afford health insurance on their own, a lot of those block grant dollars are gone. Our agency hasn't received any for several years now. And so a lot of families do fall through the cracks if they don't fit a certain bucket for funding. And I think that's an ongoing threat to our community as we see more threats to some of the grants and certainly to Medicaid and healthcare dollars as well. So I think that's something we're all going to have to keep an eye on for our community.
And with us, we're more of that connector. So if we do notice that somebody is finally saying, I want detox or I need detox, in the moment, we will right away coordinate with our community partners to see where we can get them through, whether it be them holding at FMC until we were able to get them a bed available, and then doing that follow-up as well if they do call crisis back again, being able to touch base with them. And we can see in our file where we had that communication and collaboration and let them know, like, hey, we did take you here. How did you proceed to going to the facility? What else can we provide you support with? And that's mainly here in Coconino County, just because there is that we don't have as many services here as we do in Maricopa County. And in Maricopa County right now, we did merge with LifeWell, and LifeWell does have residential and housing facilities that we are working on revamping right now. So we are restructuring and reformatting. We do have the Maverick House that now is going to be housing males. And then we have 2 new facilities that are going to be housing females, going through that process. But it's going to be a lot more information coming soon in regards to that. We are redoing that entire model in the Maricopa County. I don't know yet if we're going to be bringing that up here in Coconino County yet, but there's always, as always, there's always that resource down in Maricopa County as well. It's a facility for men going through detox, so that way they can get those 30, 60, 90 days as needed to be able to get them to the next step. So we do more like the wraparound services to get them that process. We do have an RN on site to help them. So if they're going through Suboxone, if they're going through anything, they can help them transition into a more of a sober living housing. And then from there, we connect them to our Teros facilities for continual group, individual counseling, and then any additional resources that they need.
One of the big gaps that we see in the emergency department is the lack of a sobering center in Flagstaff. We used to have one, but no longer. So is anyone working on a sobering center? Would one potentially be on the horizon?
I really am hoping this is not premature. The Criminal Justice Coordinating Council has a subcommittee to explore the possibility of moving our current juvenile court detention, probation, and dependency services center away from that Sawmill area and to turn that into a sober center. And, the detention center has 4 pods, can house 40 people. It can also be, what are the other things that they can be used for? But, services, connection to resources, all of those kinds of things. So I'm not sure, it's in very early days, but there's some excitement building. And then our juvenile court services will be closer to the King Street County Health Department and would house that teen center and then also the family resource center that we're trying to create here in Coconino County.
Well, and how can we support you in this? being able to sober up somewhere that is not the emergency department would be amazing for our patients. You know, our patients sleep and they wake up and they wander off very often without discharge instructions. And so we have no opportunity to engage with them often before they leave and provide them a list of resources. In our ideal world, you know, we would connect with them or have a behavioral health counselor connect with them before they leave the emergency department to talk about the services in the community that can support them into sobriety. And we just don't have that right now. So I am so super excited to hear about that.
I would just add that, as you know, we send people back and forth from Flagstaff Medical Center to the Guidance Center for the purposes of sobering up. Sometimes they walk through our door, sometimes they walk through your door. This was actually a conversation that we were having over lunch. The criteria to come to the Guidance Center to sober up is essentially being able to walk and talk, which isn't always a criteria that people meet. And in that case, we have no other choice but to send them to the ED, which kind of leads to the revolving door phenomenon that we're all familiar with. So I guess it's a sobering center light that we offer.
And thank you for that.
Another gap that I'm sure you're all aware of, but maybe there's somebody here with a solution, is transportation. So I also work for NIH and the Health Equity and Population Health Program Manager for Northern Arizona Healthcare. And so trying to identify when there are specific challenges or obstacles to accessing care or to having equitable care outcomes for specific populations. And something came across my radar recently that was between our, there's a gap. It's in multiple areas, but the specific case came across to my attention was a gap for getting transportation from our ED at Verde Valley Medical Center to our inpatient behavioral health up at Flag Medical Center, and transportation in general being a gap. There's virtual care, you know, to address some of that, but for those that, you know, don't have technology or just need to, you know, they're getting discharged from somewhere and need transportation back to their safe living environment. Otherwise, they're just going to be wandering on the streets or getting from one of our facilities to another. There's not a consistent, as far as I'm aware, reliable source of transportation for that. Does anybody have a magic solution?
So I did want to touch base on that. So we happen to have that issue right now in Maricopa County. Comtrans seats operations. So right now my crisis team down there is doing transport only. So with that, I've noticed also the need up here. So it's still in its pre-planning phases, but we're going to be doing a pilot program to see what it would look like for crisis to have a transportation only, non-emergency transport side of things. So we are going to pilot it in Maricopa County for right now, just to kind of see what it entails, busy hours. And we're also going to be collaborating with the community up here to see what are the busiest times, what are the needs, how can our team come in and provide that support. Since we already do mobile crisis, we are already knowing the community, we do transport as much as possible, but having that non-emergency transport only team is something that we're going to start doing and piloting in Maricopa County, and hopefully, fingers crossed, it works. And we'll be able to bring that up here as well to help close those gaps. So it's not just the care team that's going out there Monday through Friday or 7 days a week actually doing that, but we also have an additional team for that support. So it is in the process. We are working on it. So hopefully soon.
To that point, we always try to make sure a patient can get to where they're going. We paid for bus tickets as far away as Maine, just because people are traveling through. We try to obviously limit that because we only have so many patient assistance funds. But the hard part is once they get there, getting to their appointments, right? We'll often have some resources with bus passes. That's why I was happy to hear that you guys give that. But those are limited, you know, and Catholic Charities and other places may help with some of that. But knowing those resources, how to get there and do all those things, I think is what many of the challenges are. Mental health services, if you don't understand it, it's so hard to get access and all the things you have to do. And these are people that are already having enough struggles to try to navigate a system that's complex for even some of the best people in the business. So.
Yeah, so I do know transportation is a huge issue, and it's definitely something I run into a lot working with members. We have like some support Southwest can provide. We do have the bus passes, and so we always try and at intake, if they qualify, get people set up with bus passes if they don't already have that. Then we also do have a peer support on staff whose kind of main priority is driving. So we do have kind of the opportunity to help people enrolled with us get to and from appointments, get to residential treatment, get to the ED. So we do have those resources, but they fill up quickly. You know, it's like we don't have enough people on staff to really meet the need, but we are trying to, help out and assist as much as we can with that.
We at the Guidance Center have a fleet of vehicles. We also have a driver. We have patient assistant funds, and we do the very same that Todd referenced. We send people home wherever home is, but those funds are limited. I think I would just like to echo your sentiments where the largest struggle that we run into is either secure or non-emergent medical transport across counties. Crossing county lines creates huge problems. And while our county is very large, we sometimes need to send people to Yavapai or Pima or Maricopa County, and that can be a real challenge that requires creative solutions.
And patients getting transferred from the emergency department often go by ambulance, which is not a great use of ambulance resources. And, those patients get bumped. They get bumped for all the medical patients. And so that's one of the reasons that those patients wind up sitting in the emergency department for such a long period of time. And then, of course, we don't transport at night. It just creates a big backlog. So I love hearing about the transportation work that you're doing.
So in Maricopa County, and I don't know, I know the insurance access is a little different out here than in Maricopa, but in Maricopa, insurance you can actually schedule, and they work with VEO. And so insurance will pay for them to get to and from their services, medical and behavioral health. Is that not a thing out here?
It is a thing, but it's a messy thing. So you're absolutely right.
Okay.
Medicaid pays for transportation to and from appointments. However, because we're in Northern Arizona, we frequently encounter a company called MTM that is a contracted
that's what we have.
transportation provider. So in the case of yesterday, we occasionally will have a patient who needs to go from the Guidance Center to FMC. It's about a 1.5 to 2 mile drive. They will send someone from Phoenix who has a 50% rate of showing up to pick them up at the Guidance Center and drive them 1.5 miles down the road to drop them off at FMC. They will then return to Phoenix. And in an hour, when they need to go back from FMC to the Guidance Center, they will send another driver at least 2 hours from Phoenix to FMC to drive them 1 mile down the road. And we had a patient, for instance, who was scheduled to discharge to Phoenix to a birth yesterday from our hospital. MTM did not show up. And so we ended up keeping that individual in our hospital for another day with the hopes that they would show up today. So it is a real challenge, but often we end up doing a lot of transportation because while it is a covered service, it's an unreliable service in Northern Arizona.
Got it. Thank you.
And actually, we got approved yesterday, our director, Catherine Sarovi, to get a non-emergent transportation system to better serve the Cottonwood area, get patients up. And instead of using an ambulance, we're talking about how to expand that up here. I'm not sure of the exact in and out details. We don't have everything. We got approval to move forward and create that design. So we understand that ambulance is the highest transportation there is. You're better off flying across the globe than taking an ambulance across the street sometimes. So we're trying to minimize that, and we're trying to work within our confines to establish that. Casey Rucker, our security, and Catherine, how do we make it a secure transport? How do we better serve our behavioral health population to get them to our units or wherever that may be?
Okay, so right here. We're located in Prescott with the Yavapai County Health Services, and just this month we got approved for our RIDE program. And I know it's for Yavapai County residents, but it's those who qualify with any opioids exposure. So it was nice that that exposure was there. And there are like up to 6 rides. It's not for like going to the grocery store. It's for those that we see a lot of is coming out of jail, go to probation, go to your court, go to an NA meeting, go to treatment of sorts. So we're in Yavapai County, so we're figuring out how things are going right now, just being the first month having done it. But that's something that we got through a grant, right? The opioid settlement funds. Okay. So yeah, I just wanted to share that.
Wonderful. I did want to touch base too with the transportation goal that we're trying to do too, since our crisis team is in Mojave, Coconino, and Maricopa. One of the things that we're hoping for is to be able to collaborate transporting from Coconino to Maricopa, Mojave to Maricopa, since we do have services there. So that's the goal as well with that cross county area, kind of figuring that out. Just because up here it's Arizona Complete Health, and then in Maricopa County it's Mercy. So there's that difference as well. So we're trying to figure out how that would work. But we're hoping to be able to provide those services and looking at what that will look like, and also collaborating with other counties and at least meeting like in the county lines, and then doing like that, handoff, warm handoff, and then kind of transporting, trying to find the loopholes and all of that. But we are looking into that and working on that.
I think we all understand the value and importance of having peer support at every level of care. So making more room, more space on your staff for that. And then what's it going to take to make 60 days, 90 days for residential be more the standard? Like to me, that's a bigger question, but.
All right. So thank you to our panelists and for being so brave this afternoon, especially after lunch, when everyone wants to just be quiet. You were brave enough to get up into the front of the room and talk. Thank you so much. So we're running a little bit over time. We have just one other item left before we wrap up. Nick and his team have worked really hard on a graphic for today because we really wanted to put everything together. And so this is our road to recovery with patients starting at the bottom of the road here, accessing services. Maybe coming into contact with a hospital, the emergency department, or inpatient services, then maybe progressing to residential services, and then leaving residential services and hitting our outpatient, our services. We had hoped to print out this graphic and put them in sections of the room. But unfortunately, the internet was not behaving and the printer wasn't behaving, and so we weren't able to print these out. But we would still like to invite everyone to help us out to fully characterize the services that you're providing. So, right, and then we'll take about 10 minutes for that, and then we'll wrap things up for the day.
If you need CME, CEU, I talked with our CME director up at NAH. If you're interested, Nick will send you an email. If you're interested in getting credit, all you have to do is say, yes, I want the certificate, and you can use it for Category 2 CME. And for nurses or other professionals, you can use CMEs as well. So if you're interested, and we're sorry we didn't have it pre-set up, but we had some delays in we had so many people that needed to do the packets. But you can still get CME credit. You just need proof with a certificate, and it's 4.4 hours of CME that you can get. So it's Category 2 CME. But Nick will send out an email and just let him know, yes, I want a certificate, and we'll get it to you.
So I just wanted to thank everyone for coming today. I wanted to thank our panelists for being brave enough to sit in the front of the room and talk about their services. A special thanks to Dr. Gibson for putting together her talk. I learned a lot today. I am so impressed by all of you. So thank you so much for all you do.
Thank you all. How about a round of applause for Dr. Khan as well? Great job putting this together and bringing an amazing team. I have to admit, as we wrap this up, here are our dates for our future workshops. But I just want to say, we started the day with Dr. Gibson talking about social connections and the need for care. And that was the purpose. And this was, I think, Jen's underlying vision of this was to help you all make connections to better serve the people that are in need. So hopefully you made some great connections with that today. I was blown away as we hear about, here's our outpatient panel. It really sounded like, what do you need? We got you, right? So you all are an amazing community. What you are doing here can be a model I think people can learn from you across the state. But also that's where I'm glad we had Sammy from Crossroads, and we've got Teros, we've got folks across the state that we can learn from as well. So hopefully you made connections. Once again, thank you, Dr. Khan, and to you all for coming today. You all have a wonderful weekend.